speaking on types of ptosis. Dr.
Thank you so
Anju,
much
can you
for
share
the
your screen?
invite. It's sharing it right away. I hope it's visible.
Yes, it's visible,
Yes.
ma'am. You can change it to slide mode, please.
Yeah. Now, is it visible in the slideshow mode?
Yes, yes.
So, first of all, thank you so much for this module. And as you all know, ptosis is a long case for exam. And the moment you hear a ptosis case, I'm sure most of you are petrified. Let me see if I can simplify this for you by the end of the session. So, what is true ptosis or what is blepharoptosis? The simple definition is the drooping of the upper lid more than 2 millimeters in such a way that more than 2 millimeters of the cornea is covered. So, ptosis can be broadly classified into congenital or acquired. It can be unilateral or bilateral. Taking you through the simple classification that we have, like I mentioned, we have a congenital and acquired causes, but congenital can again be a simple presentation of just ptosis, or it can be complicated, whereby it is associated with various oculomotor involvements, such as a monoocular elevation deficiency or congenital third nerve palsy, associated syndromes such as blepharophimosis syndrome, and synkinesis such as Marcus-Gunn jaw winking. If you're looking at the acquired causes, then you have the neurogenic, which includes third nerve palsies, Horner syndrome, and myogenic, which are the mitochondrial myopathies, such as the chronic external ophthalmoplegia and the oculopharyngeal dystrophies. And targeting the neuromuscular junction is myasthenia. And a common form of acquired ptosis is the aponeurotic or the involutional type, where there is dehiscence of the LPS or the levator muscle, and mechanical, where there is an upper lid lesion. So, a common question that is asked to most students during their viva is the difference between a congenital and an acquired ptosis. So, as you know by the term, it is present since birth, and the pathogenesis here is due to the muscular dysgenesis of the levator palpebrae superioris, because of which the muscle can neither contract nor elevate. So, this is most often associated with an absent lid crease. Lid crease may be present in cases where there is a Marcus-Gunn jaw winking. The presence of Marcus-Gunn jaw winking should indicate towards a congenital cause. So, because of the pathogenesis of congenital ptosis in the muscle, while looking down, you can see that in the affected eye, the lid is at a higher position compared to the normal. Whereas we looked at the various causes of an acquired ptosis, and this is never associated with Marcus-Gunn jaw winking, but there are other synkinesis that might be present. And you can see multiple faint lid creases or a high lid crease, showing that the LPS muscle has receded posteriorly. And on down gaze, you can see that the total lid is lower than the normal lid. Now, we talked about true ptosis. So, there must be a pseudotosis. So, these are cases which mimics a ptosis, where the patient may have a lid retraction in the other eye, or might have a case of inophthalmos or anophthalmos, like in phthisis bulbi, and this patient who has a prosthetic shell within, which appears like ptosis. And also this elderly woman, where she has bilateral brotosis as well as dermatochalasis mimicking a ptosis. So, a detailed history is required to find out whether it is present since birth, whether it is progressing as in case of an acquired cause, whether the patient has any history of frequent eye rubbing in allergies, contact lens use, recurrent episodes of edema, such as in young adolescents, which is referred to as blepharochalasis, leading a secret paper appearance like this, and any associated difficulty in breathing, change in voice, swallowing, any diurnal variation in the presentation, any history of trauma or previous ocular surgeries, or a family history such as in BPES, which we will be seeing, and a FAT scan. So, what's a FAT scan? It's a family album tomography whereby you look at the serial pictures to find out whether it was always present or whether that patient has acquired over a period of time. Now, how do you break down examination? So, this is the moment the patient enters your OPD, you start examining him by looking at the way he places his head, whether there's a chin elevation where they compensate for the ptosis, and the presence of frontalis overaction. And by shining a torch at the patient in a primary gaze, you can elicit the Hirschberg's corneal reflex, where in a child like this, you can see that there is an associated esotropia and hypotropia. And you cover one eye and make the child fix with that eye, and then you begin measuring. So always an examination begins with visual acuity, which is important to rule out amblyopia in children, which can be done by occluding the better eye and looking for the vision in the affected eye. Pupillary examination, such as in Horner syndrome, in third nerve palsy, and ocular movements to look for monoocular elevation deficiency or third nerve palsies. So once you have seated the patient comfortably at your eye level with the head faced in a primary gaze, the next thing that you need to know is to negate the frontalis action. By doing that, you can clearly see how your measurement has changed. Now let's take a closer look. Palpable fissure height basically refers to the distance between the upper lid margin and the lower lid margin. And on shining the torch at the eye, you can see that the measure of the distance from the upper lid margin to the pupillary reflex will give you the marginal reflex distance, which is important in the measurement of ptosis. And the remaining from the pupillary reflex to the lower lid margin will give you MRD2. Please note, palpable fissure height is a sum of these two. And in normal conditions, it is 4 to 4.5 MRD1. And if it is in a case of ptotic eye such as this, on elevating the upper lid is when you get the MRD2, and hence MRD2 is more than palpable fissure height, and your resultant MRD1 is a negative value. Now, based on the severity, like I said, the normal is 4 millimeters. So you compare it with the normal value or with the other normal lid, and it can be classified into mild, moderate, and severe as 2, 3, and 4 millimeters respectively. Now, this is an important surgical landmark where marginal crease distance is the distance from the most prominent lid fold to the upper lid margin. The normal values are there for you to see. And the most important part is the levator function test measurement, which is done with the help of a simple ruler, where the patient is asked to look down completely after negating frontalis action and look up completely. And the distance through which the upper lid has traversed will give you the measurement of the levator function test, which is excellent, which is more than 12 millimeter, good if it is 8 to 11 millimeters, fair if it is 5 to 7 millimeters, and poor if it is less than 4 millimeters. And in children, you can do a simple test called an ELIF test, where you evert the lid and look for whether it comes back to normal quickly. Now, in a patient with a pre-existing lag of ophthalmos, it needs to be noted because post-surgery it can worsen. Bell's phenomenon, as you all know how it has to be elicited against a forced closure. You try to open the eyes and look for the cornea, whether it has rolled up and laterally. And lid lag on down gaze we saw earlier. And also Marcus Gunn jaw winking is done by asking the patient to move the jaw from side to side or by simply eliciting chewing, which will cause a difference in the lid height in the ptotic eye. Now, a phenylephrine test is done in cases of mild ptosis, whereby phenylephrine, a concentration of 2.5, is instilled into the ptotic eye in the superior cul-de-sac, and you wait for about 5 to 10 minutes and wait for the effect to come. And if there is an improvement of more than 2 millimeters, it indicates that it is positive. Now, a Herring's test is a simple test where the ptotic eyelid is elevated gently and you look for any change in the distance in the other eye, which will unmask a hidden ptosis. Now, no test is complete without eliciting these tests, which is fatigability test, which can be done by making the patient look up for more than 30 seconds. And you can see that the lid slowly begins its descent. Cogan's lid twitch is saccades of the lid when you suddenly ask the patient to look at the primary gaze after having rested for 30 seconds downwards. And an ice test, which can be performed in the OPD, whereby you place an ice pack for about 2 minutes on the ptotic eyelid and you look for an improvement of 2 millimeters or more in the palpable fissure height. Schirmer's test and corneal sensation will help you find out if there is any pre-existing ocular condition that you should be aware of before you suggest surgery for the patient. Otherwise, it can result in exposure keratopathy. Now, Hertel's exophthalmometry is to complete the examination to detect if there is any associated proptosis that you need to be aware of. Now, like in any ophthalmology case that is given to you, no examination is complete without having a thorough look at the anterior segment. In this particular gentleman, you can see that there is a ptosis in the right eye, but on elevating the upper lid, you can see a hidden salmon patch. Often even amyloidosis can present with ptosis, so everting the lid is equally important. Fundus examination is a must in all patients, such as in mitochondrial myopathy, such as CPEO. There can be a salt and pepper retinopathy, which also needs to be indicated prior to the surgery. So here are my take-home points. You need to always take a detailed history, maintain a checklist while examining a ptosis case, because there is no shortcut to memorizing a ptosis case. You need to do it from time and time and do the measurements till you get thorough with it. And always, when you see a case, have a provisional diagnosis in your mind, and the diagnosis should mention whether it is unilateral or bilateral, what the likely etiology could be, what is the status of the LPS function, and also whether there are any other associated synkinetic movements that you need to be aware of, along with the condition of the Bell's phenomenon and any other predisposing ocular findings if you get. So, since this is a very big topic, so here I have you, if you scan this QR code, this will lead you to a PDF, which will give you most commonly asked questions during Viva and theory, which you can go back and read. And I hope you found this session useful. Thank you.
Thank you, Dr. Anju. That was indeed a very enlightening session, and you have tick marked all the check boxes for the postgraduate learning.
Yes.
Modini ma'am, would
Yeah,
you
that
like to
was an
add something, ma'am?
excellent presentation, Dr. Anju. Very, very comprehensive. And like you said, it's really a huge topic and a really good thing. Just wanted to add one thing for the postgraduates. I know you've said it, but it cannot be said enough. Always your palpable fissure height should be equal to your MRD1 and MRD2. If you get any of these measurements wrong, you need to go back and review all of them again. That is all I wanted to mention. And I always like to ask a favorite question to my postgraduates in the exam, that if we allow you only one measurement in a case of ptosis, what would that be? The measurement of choice. We don't allow you everything, only one. So is it an interactive session, Dr. Praful? Can they listen to us?
Ma'am, we can ask the participants to just answer that in the comment section.
Okay.
Yeah.
Okay.
So
Okay.
those who have heard the question can answer that in the comment section.
Yeah. Excellent talk, Dr. Anju. Looking forward to hearing more from you in the future.
Thank you so much, ma'am. Thank you.
Dr. Swati, can you please invite the next
Yeah, so with
speaker?
respect to the time, I would like to invite my dear friend, Dr. Sonam Nisar. She's a senior consultant at Shankar Netralaya, Chennai, and she would be speaking on management of ptosis. To you, Dr. Sonam.
Thank you so much for that kind introduction. And at the outset, I'd like to thank Dr. Prabhula and team for this beautiful initiative for scratch. Are my slides visible?
Yes, they are visible.
Fantastic. So I think my colleague, Dr. Anju, has actually spoken in detail about the introduction, etiology, clinical grading and evaluation and diagnosis. And she's beautifully covered everything there. So now, when you are at the level of deciding the management, like Dr. Anju clearly said, you have to know whether it's a unilateral or bilateral ptosis, whether it is congenital or acquired, whether it is mild, moderate, and severe, what is the LPS action, whether it is good, fair, or it is poor. How is the Bell's? And to add to that, I'd like to say that Bell's, when you're assessing, it's not, I mean, you would also like to look at passive Bell's in that case, because when you're sleeping, that is a time where the exposure might be the maximum when the Bell's is poor, because when you're doing a ptosis correction, you know that the lid might not close completely later. Also, a lot of these patients have pre-existing lag of thalamus, and that must be documented as well. So now the tests and all have been beautifully covered. What would be the documentation that we'd like to do pre-operatively for these patients besides the clinical evaluation? Of course, vision mandatory in all cases. We are first ophthalmologists. Like I mentioned, a degree of ptosis. Very, very important photographic documentation as well. Because sometimes, for all you know, the parents or the patient might be just focusing on one eye, but the other eye also might have some mild to moderate ptosis there. Next is imaging where required. So, like in cases where you are not sure of your complete diagnosis, where you have myopathic ptosis or neurogenic ptosis, it is always safe and good to get an imaging done in these cases. Often you'll see that in CPO, it will be thinning of the extraocular muscles. You'll notice that in third nerve palsy, you'll see at the level of the third nerve, there might be some injury or an aneurysm, which is actually causing the third nerve palsy. So before you go in and touch the patient, imaging is also important, when in doubt. Also, in cases where you might have a history of injury, there might be pseudotosis. So that is another area where you'd like to do your imaging. Counseling, oral and written consent important for all the patients. Now, this has been dealt with in detail by Dr. Anju, and I'm not emphasizing that. One important point
Dr.
is
Ashwati, can you please mute yourself? Sorry, Dr. Sonam. Dr. Ashwati Neena, can you please mute yourself?
so one important point is you ask the patient to look down. A lot of these patients with congenital ptosis will have a pre-existing lid lag and down gaze, and that will worsen once you do a ptosis correction. So counseling these patients is also extremely important. Another thing is this syndrome, as it has already been mentioned, BPES. So what is this syndrome? It is blepharophimosis epicanthus inversus syndrome. So here you have ptosis, you have epicanthal folds, and you have telecanthus here. A favorite question for all the examiners would be, when you get a patient like this, what would you address? So first, generally, if you're planning to do both correction together, then first you address the telecanthus and the epicanthal folds, and then as a stage procedure, you can do a ptosis correction. So that is one of the favorite questions, and that is how you decide for BPS. It's very important to know the protractors and retractors of the eyelid in anatomy, because that will help you understand the principle of ptosis correction as well. So what are the retractors of the lid? You have the LPS muscle, you have the Muller's muscle, and you have the frontalis muscle. So Muller's muscle, if you do a Mullerectomy, you get a correction of about 2 to 3 millimeters there. When you're looking at the LPS muscle, of course, you have to assess the action of the muscle, and then you can either plicate it if it is disinserted, or you strengthen the muscle. And last is the frontalis. So your tarsofrontalis sling surgery is based on the fact that frontalis is also one of the retractors of the eyelid. So you can either do a tarsofrontalis sling, or you can pull the frontalis muscle from up right onto the tarsus like a frontalis muscle flap. So these are the various surgeries in brief. As I was mentioning of the principle, if the muscle is weak, you tighten it, or if it is disinserted, you plicate it. If there is a mechanical ptosis and you know it, like in case of tumors, then you address the primary cause. On case of neurofibromatosis, where you have a bulky eyelid, you address that and then you do a ptosis correction. Timing of the surgery is very, very important. So normally in preschool going age group is the best time to do the ptosis correction. However, early ptosis is indicated if there is an impending amblyopia or any tropias are there. In case of neurogenic ptosis, you'd like to wait for at least 6 to 8 months. And as I mentioned before in BPS, assess the telecanthus and epicanthus first, operate on that, and then go ahead with the ptosis. If there is any associated squint, for horizontal deviations, you can move into combined approaches, as we know that there might not be any alteration in the lid position. But if there are vertical deviations, you first address the squint and then you go ahead with the ptosis correction. So now, based on the degree of ptosis, mild, moderate, and severe, and the LPS action, you have like a plethora of surgeries that are available and described. Fascicular Servat, though quite historical, is still being done, and that is one of the favorite questions of a lot of examiners. Then you can do, when you have a moderate degree of ptosis with a good LPS, you can either do a Fascicular Servat, or you can do a resection, or you can do a conch millerectomy also sometimes. If you have a fair action of LPS with moderate ptosis, a large resection can be done, and you can do a maximal or supramax levator resection, Whitnall sling, in cases with poor LPS with moderate degree of ptosis. With very poor LPS and severe ptosis, generally it's a frontalis sling surgery or a frontalis muscle flap that has been advocated. So now, what are the indications of Fascicular Servat and what is the principle of Fascicular Servat? I'll just quickly run through this video. So basically what you do is you invert the eyelid and you excise the tarsus along with the articulars and the overlying conjunctiva. Nowadays, we don't really prefer that because if you excise the tarsus too much, it can lead to entropion. It can lead to posterior lamina scarring. So this is not a very favored procedure. What are the indications? Indications would be like very minor disability, function, corneal syndrome, or where you go through some minor adjustments after a primary surgery. So these would be the indications for Fasanella servat surgery. Now, this disadvantage is that it does not allow you to alter or grade it once the surgery is done. It obviously sacrifices the tarsus and conjunctiva. There's a higher rate of recurrence. It can lead to corneal abrasions, altered contour, foreign body sensation secondary to the sutures that are there. And you may not get the desired lid crease in this procedure. One of the most beautiful surgeries, that is the conch mullarectomy, can be done in mild to moderate ptosis with good levator function. You can do it also in Horner syndrome. It generally gives you a lift of 2 to 3 millimeters. Now, the prerequisite of this surgery is, as Dr. Anshul mentioned, you can do a phenylephrine test in the OPD itself to see how much lift you are getting. And added advantage here is you can take crease on the sutures after doing the surgery. What's the principle here is you invert the leg, identify the Muller's muscle, which is on the superior border of the tarsus. It's attached there. This is a very important instrument, and that's a Clemens clamp that you use to clamp the muscle. And then you excise it in. And then you take, you take continuous sutures to close the residual effect, which is there. This will give you a good lift of about 2 to 3 millimeters and can be done at moderate doses with levator function. Next is one of our favorite surgeries, that is levator plication or levator resection. It has two approaches. It can be done either through anterior approach, that is transcutaneous, or posterior approach, that is transconjunctival as well. Now, each surgeon has their own preference, but more or less, when you're doing it transcutaneously, you also get the chance to form a very good lid crease as compared to posterior approach. What are the indications of levator plication, levator resection is when you have a good LPS action, moderate to good LPS action, and you have high to moderate doses. In patients who are very poor LPS action, this is not preferred choice of surgery in those cases. The principle is the same that I was mentioning before. If your LPS muscle is disinserted, you identify it and you reattach it. If it is like fibrotic, or you see that there's a fatty infiltration, then you can go ahead and also resect the muscle and tighten it and excise the excess muscle. Normally, as per the books, 1 millimeter of ptosis, you generate was 6 millimeter of plication. Now, this is a very good pictorial documentation to just show the steps. You take first a lid crease incision, you identify the most prominent lid crease on that side, or you compare it with the lid crease on the other side and form the lid crease. Once you take the lid crease incision, you dissect the skin, orbicularis, and incise the orbital septum till you come to this figure number 3, where you're seeing the pre-aponeurotic fat pad, which is prolapsing there. And you see this whitish, shiny structure, and that is your LPS aponeurosis. Once you tag the LPS aponeurosis, then you can measure it, dissect it towards the superior orbital rim. You can plicate or you can excise it, that is, you can resect it. As per the textbook, as they say, at the end of the procedure, if your levator function is poor to fair, the lid height has to be placed in resection at the superior limbus. If it is fair to good, then lid height can be placed 2 to 3 millimeters below the limbus, because when you resect it, it will eventually contract and lift up after the surgery is done. Now, this is a very classical textbook table that is there, which all the postgrads can literally by heart. But to be honest, this is not something that we follow in practically. We decide a lot of things on per-operatively and on the table, how much the lid is lifted. But this is something that postgrads must know. How much amount of ptosis versus LPS action and how much amount of resection that must be done. One thing is, anything more than 27 is termed as a supramax levator resection, and that is very limited. Whitnall suspension is also another surgery that you do when the levator function is between 4 to 5 millimeters. And just the thing is, it's almost similar as that to LPS plication there, but you go all the way up till the Whitnalls. So if you see the shiny structure, that is your LPS, and you see this white line right on the top at the superior orbital limb, and that is your Whitnall's ligament. So this can come down later. There's a high chance of recurrence because the sling can become loose eventually. So a lot of us do not prefer this, but yeah, a lot of people will ask you this question in Probably. Now, next is another surgery which has a lot of indications and implications. Frontalis sling surgery. This is basically done when you have congenital ptosis or when there is poor LPS action. Cases with BPS, myogenic ptosis, third nerve palsy, Marcus-Gunn jaw winkling, it's very severe ocular myasthenia gravis. So you have two techniques here. You have Fox pentagon. You can just look at the diagram and draw the same thing in your examination. This is Fox pentagon, and then you have the Crawford, which is a double triangle Crawford technique. So these are the two techniques that you can use. What are the materials for frontalis sling suspension? It's one of the most common questions. You have autologous and synthetic or allogenic. So in autologous, you have fascia lata, which is the most favorite. Then you have palmaris longus tendon, temporalis fascia, or frontalis muscle. Synthetic, you use most commonly the silicone rod. You can use a Gore-Tex suture, nylon, polypropylene, or you can even use bovine sclera or bovine tissues, which are available. Advantages of a sling is that it is elastic, easily available, and you do not have to take another incision at another donor site. The advantage of an autologous fascia is that there's less risk of infection or rejection. Overall, it is the surgeon's choice. And this is just a small picture, actually, it's a full video, but this just shows your incision of the fascia lata. And this is something that the examiners might ask you, that what is the surface marking of fascia lata? You take the first incision 5 centimeter above the lateral condyle of the tibia, and second incision is taken at 10 centimeters above the first one. So that is the surface marking of the fascia lata. Then you have the frontalis muscle transposition flap, which is there. This is a very beautiful diagram from this journal that you can just copy and put it in your examination when you're asked to write a question. Just above the brow, you take a lid crease incision, you dissect all the way up till the brow, identify the muscle and bring it down. There are multiple modifications of this, but for examination purpose, this is just a very good diagram. Normally, we do not do fascia lata or frontalis muscle flaps less than 3 years of age because the muscle still has to develop. Less than 3 years, ideally, we prefer a silicone rod. Now, what to expect immediately is this. You will have a lot of lag of ophthalmos, so you can take a lower lid frost suture in order to cover the cornea. Immediately at 6 weeks, you will see that there's still a little bit of upper lid edema. You'll see that there is a lid lag in down gaze as well as in up gaze. The lid doesn't go up completely like the normal eye, and this must be counseled to the patients. Another thing, this is finally at last visit. Lag of ophthalmos is one of the common things that is seen generally post-op, and that must be counseled to all the patients. Now, what are the complications following ptosis surgery? This is an important question. Obviously, in any surgery, you can have an undercorrection, you can have an overcorrection. Because of the lag of ophthalmos, when you're pulling the lid up, you can have exposure keratopathy. And at that point of time, it is extremely important to understand that Bell's phenomena plays a very important role here. So this is a child, as you can see, has lag of ophthalmos while he's sleeping. He has poor Bell's. And you can also see another complication here, that the sling has been exposed right here. So you can have recurrent suture granulomas, you can have a sling exposure, sling infection, you can have notching of the eyelid, abnormal contour. If you are plicating it very high, you're resecting it quite high, you can have a conjunctival prolapse in LPS resection surgeries. And sometimes you can have entropion or ectropion also, depending upon how much you are plicating or if you're resecting any extra skin. Here, picture that you can see very weird lid creases. So you have multiple lid creases in this patient, and that also is not a very good cosmesis. Also, if you look at the contour, it's not a very acceptable contour here. Besides that, you can have diplopia or hemorrhage or infection that is standard for all the other surgeries. So in case you have an undercorrection, you can always go in and tighten your sutures. If you have an overcorrection, you can ask the patients to do lid traction exercises, orbicularis exercises, that is forceful blinking, or you might have to go in and loosen your sutures. For exposure keratopathy, have to maintain on copious lubricants. Ask them to voluntarily blink the eyes a lot. And also, if nothing is working, you might have to loosen your sutures or do an undercorrection. If there are multiple episodes of infection of the sling or there is a suture granuloma, Then you have to treat that. And if you're using a silicone sling, you can go into use an autologous material post that. Any other lid malabnormalities or malpositions can be corrected as and when required. Now, there's another beautiful non-surgical option also when nothing works and you feel that there have been multiple surgeries and nothing's really worked for a patient. So here you can see a patient with severe ptosis, myopathic ptosis with poor bells, and we just gave him a crutch glasses, and that also is a non-surgical option for management of complicated or complex ptosis. Now, some bio-OC questions. That I had prepared. Here you can see that there is a 66-year-old female with progressive ptosis. If you look at her, you can see that in the left eye there is severe ptosis because it's covering the visual axis. You see the MCD, that is margin crease distance, is much higher as compared to that on the other side. She also has some broad ptosis and lash ptosis. So a simple LPS plication was done for this patient, and here she looks very beautiful. You can see the symmetry in the lid crease. You can see the lash ptosis also being corrected. Now that was a aponeurotic ptosis, but look at this. This is a congenital ptosis. You can see that it is a severe ptosis, again has lash ptosis, but look at the lid crease. Here, the lid crease is quite faint here as compared to that what you see in the previous picture here, which is receded. One of the indications of poor LPS function in pediatric age group, you can do ellipse test. That is, you can just invert the eyelid, and if it is not going back immediately, that means the LPS action is probably poor. Another indicator would be your eyelid crease as well. And here is another patient. You can see here. Why have I shown this picture? Because this is a case of Marcus-Gunn jaw winkling ptosis. You see that when the patient's opening his mouth, it's almost symmetrical. Now, in these cases, there are two options that you can give to the parents. One is if you want to get the jaw winking reflex negated, you have to do an LPS excision followed by a ptosis surgery, or you can just do a frontalis sling surgery, which will dampen the Marcus-Gunn jaw winking reflex. This I've already discussed is a case of BPS wherein you do address both the telecanthus and epicanthus first, followed by ptosis. And where you have mechanical ptosis because of condition like this, always go in and assess the face. Also, you see multiple caveolar spots there. This is a case of mild neurofibromatosis. You debug the lesion and just do an LPS plication, and that's the result. Thank you so much. Thank you for your patient listening, and sorry I was short a little bit.
Thank you. Thank you, Dr. Sonam, for the very comprehensive. Ma'am, Dr. Modini, any comment from you, ma'am? Quick comment. So, ma'am, you are on the mute, ma'am. Kindly unmute yourself.
Yeah, I've seen Sonam evolve from a totally enthusiastic and young postgraduate with stars in her eyes to this suave and sophisticated surgeon that she's now. Well done, Sonam. It's a big topic, and she's managed to cover it well. I think there's not much to add because she's covered everything. And congrats, Sonam. Well done.
Thank you.
you.
So we have Dr. Puneet with us. Dr. Puneet Jain, are you with us today? Dr. Puneet? I believe he's not
No,
here.
Sumit. Puneet is not well. So he
Okay.
won't join today. Okay. His lecture will be on
So we
Sunday.
can take.
Okay, sure. So now I invite Dr. Modini Pandarpurkar, ma'am. She'll be talking about lid repair, the practical pearls. Ma'am, over to you, ma'am.
Share it, share it first. I'm just sharing my screen.
Yes, ma'am. You just allow it, ma'am, everything.
Just give me a minute. WhatsApp मध्ये आहे. इथे आहे ना कुठेतरी डेस्कटॉप. One second. It's on the desktop. Okay. हे करू बंद. ओपन करा मग शेअर. Yeah, can you see?
No.
Yes, ma'am, we can see.
Okay, so the topic given to me for today's talk is about reconstructing the lid. And here you see a few situations. I'm going to skip some slides in interest of time. So these are a few conditions like congenital or with trauma and with a tumor which we excise and then have to reconstruct the gap left there created by us. These are a few situations where we need to reconstruct the lid. And these are just indications. You can read them like colobomas. It could be congenital or a traumatic coloboma. And I always like to, in the beginning of reconstruction, read this line by Jack Mustade, who wrote it in 1916, a very old line, but which holds good even today. He says, when the eye is still present, reconstruction of an eyelid or even a part of it requires a minimum of 3 layers. We know very well that the lid has 3 layers: an outer layer, an inner layer of mucosa, and a semi-rigid skeleton between them. This holds good even for today. And based on these sentences, we have to follow, all our principles are going to follow what Jack Mustade said way back then. So evaluation of an eyelid defect is very, very important, and a pre-op assessment is very necessary to plan your surgeries. So you have to look
Sorry to
whether
interrupt you, ma'am. Ma'am, you
Hmm.
can change it to the slideshow mode.
Yeah, I will.
Yeah. Thank
Yeah.
you.
Yeah, that's good. Okay.
Ma'am, that's very nice. Thank you.
Yeah, no, that's okay. So you first look whether it is a full thickness or an anterior lamellar defect. Then you evaluate the size of the defect, which is generally spoken of as 1/3 of the lid, half of the lid, more than half, and etc. Whether the margin is involved, whether the canthi are involved, whether if it is the medial canthus, whether the lacrimal drainage system is also involved. What is the age, which tells you how lax the skin is and how much you can pull in to reconstruct. And of course, how is the contralateral eyelid. So assessment of the defect, again, these are the few circumstances where you say there is a marginal defect. This is the reconstructed defect. Here again, this looks very falsely as if there is no canalicular tear, but if you examine it, there is going to be a canalicular tear and you have to be prepared with a stent. This is the way we have sutured it. Or a condition like this where there is tissue loss also. So the main principles which guide us when we are reconstructing a lid are: we need adequate eye closure. We need a good tear film preservation, because as you know, the blinking of the lids is what spreads the tear film on our surface of the globe, and it is preserved. It is also produced by the glands inside the lid, and also it is moving the tear film over the globe. It also maintains an unobstructed visual field if it is properly constructed, because we do not want the visual field to be compromised. If there are full thickness defects, you need to make both lamellae reconstructed, and with the muscle anteriorly, and conjunctiva must be there posteriorly, because you do not want a rough margin to rub on your lid. You can only take, if both layers have to be reconstructed, only one can be taken as a flap. The other may be a free graft. Because flap, you cannot have two free grafts, one on top of another, because the vascular taking up of the graft, the retaining of the graft may become a challenge. Vascularity has to be there either in one lamella, and anterior or posterior. The other can be a free graft. Depending on your defect and where it is, you decide which lamella you want a flap and where you want a graft. Another thing you should remember when you're reconstructing a lid is every scar you make should be parallel to the skin creases, which minimizes the vertical tension and will avoid your notching. Canthi always should be fixed anatomically, because they are the fulcri on which the lids move, open, close, and the tear film is spread all over the globe. So these are very important to be fixed anatomically. Then, of course, match like tissue to like tissue. Narrow the defect as much as possible before you take the graft. So you try, because skin is very elastic, they retract when there is trauma. Hold the two edges of the cut ends with forceps, try to bring them as close as possible, and then only size your graft, so that you will get away with the optimum size of graft. Of course, always choosing the simplest technique is the best method to do. This is an illustration just to demonstrate that lines of Langer, these are the lines of Langer in the face. And this is the question for the postgraduates: why do they matter for scar formation and cosmesis, which they can answer in the chat. I'm not going to tell them now. So you have to achieve finally a stable eyelid margin, which is required for a tear film stability, to spread the tear film, also not to injure the cornea. Then there should be adequate vertical and horizontal dimensions. Otherwise, you have a leg ophthalmos or open lids when the child attempts to sleep or the person attempts to sleep, which does not really protect the cornea. That's the next point. Then a smooth mucosal inner surface, because you do not want the cornea to get abraded. Of course, the last goal, also a very important goal, but the last one we think of is a cosmetically pleasing symmetry. Anatomy of the lids, I'm not going to talk about. You know very well, there are two lamellae. This is showing you that there is a lot of vascularity, which is very important in the healing. And there are glands and there is a tarsal plate. So you have to consider all these lamellae when you're reconstructing to try to substitute them with a flap or a graft as it is. The canthal tendons, as we already spoke, are the fulcri on which the lids move, and you need to anatomically align them if they have disconnected or if they are torn at the time of the injury or in your surgery where the lesion extends up to the canthus almost. The lacrimal system is another thing which you need to consider very importantly. So be careful when you're doing any medial area reconstructions, so as not to disturb the orbicularis, which is responsible for the closure and opening vacuum creation in the lacrimal sac. Also maintain the intactness of the lacrimal drainage system. Now, for lower lid reconstructions, these are the options we have. Where for young patients with tight lids, which we call as 25 to 35% defect, we classify into small defects, medium defects, large defects. For older, again, we classify in the same way. The reason why we have separated older and younger is because we have different methods of reconstruction. Older people have lax skin and we can get away with most of the we can get away with a smaller procedure. Now, the margin has to be stabilized first. Please note these pictures. The marginal suture has to be placed in such a way that the margins are slightly everted. So when they settle down and heal, they will settle down in a straight manner and in not notching, because a notch is quite detrimental to the spreading of the tear film. These are, you apply 3 marginal sutures generally, the middle one at the gray line, the inner one at the conjunctiva. Can you see my cursor on the screen? Hello?
Yes, ma'am, we are able to see the cursor, ma'am.
Okay, so the conjunctival side and the lash line to lash line. So then it opposes your lid anatomically, and then you go and suture the tarsus. Sometimes in practical, these sutures may not really oppose the lid if the defect is large. So it is okay if you take one tarsal stitch first to oppose it and then go and do the lid marginal thing. The orbital septum never to be sutured because it will cause a cicatrix and a contraction. You have to leave it alone. Small conjunctival, of course, can be left alone. So this is a picture of the marginal tear where you see there is an apparent tissue loss, but when you pull these two together with forceps, you realize that there is no tissue loss as such, and you can approximate it properly. This is a picture. You only have to take care of the margin being intact. This is a vicryl suture, marginal sutures, which I like to leave long, pull them up and tie them, and then we cut them after a few days, so that the rough cut edges may abrade the cornea. We don't want that. So in lower lid reconstruction, direct closure is available to us, where you can directly approximate if the injury, if the tissue loss or the lids are not very far apart, the 2 cut edges. Lateral cantholysis to give you an extra space. We will see examples of this. I won't go through this slide. So in 30% defects and up to 45 in older patients, you can get away with direct closure. If you want to do a lateral cantholysis, you get a 5 millimeter additional area to pull it. And always the tarsal defect should be squared. What I mean by that, I'll show you through pictures. So this is an example of a direct closure where you can directly close. This is an excised tissue for some tumor apparently. So you're closing it directly, and always the skin incision should be placed in a lateral manner where this defect has these, the edges have to be squared or have to be parallel to each other. And the tarsal plate has to be cut totally in toto. Even if there is a half length of tarsal plate is available, you go back, create a full, the full length of the full height of the tarsal plate has to be excised, then only you can square the defect. So this is an example in an older person, small defect, direct closure. You can see that in older people, you can get away even with higher degree of the defect, a higher degree of apartness of the lids because there is laxity of the tissue. You can see the lower lid and the upper lid have been almost directly approximated. Tarsal defect is always squared. These edges have to be always parallel to each other. If they are not squared, this is what happens. This is what you land up in when you want this result. So this was a case outside and they had not bothered to square the tarsal defects, and they have created a cicatricial lagophthalmus of both the upper and lower lids. We went back, opened it out, and we created again another horizontal incision because always we said respect the creases, respect the lines of Langer, and there you can see the result now. So lateral cantholysis is a procedure which gives you 5 mm of advancement. And here you can see there was a tumor at this site, and we just did a canthotomy cantholysis, and got away where we corrected it. You can see that this is pulled in, and here is where we approximated it. Here you must be sure that you have to angle the skin incision always superiorly, because you want the lower lid to be pulled up to the center of the orbital rim. That's the Whitnall's tubercle. So you have to angle this upwardly and anchor the muscle layer to the periosteum after you close the defect. So not only do you align the canthi, or not only, you also attach these muscles also, you approximate for a proper contour and proper position of the lid. Then this is another example of a lateral cantholysis, where this child had a trauma in childhood, and this was what was left of the lid. We could get away with the lateral and a modification of, we pulled in tissue from here, and that is the end result. So this gives very good approximation for the lower lid and does not even close the eyelid. Tenzel's flap is for larger defects, where you take in the tissue from behind the lateral canthus also to correct your defect. It can be used for the defect at any site, works best for medial or lateral defects. And up to 60% you can take. Here the flap must arch upward for the lower lid and downward for the upper lid. We'll see later. And additional support of the lateral lid, again, periosteal rim can be taken from the lateral orbital rim and attached here for additional support, so that the lid is suspended properly, because the suspension of the lower lid is very important for functions. So this is an example of Tenzel's. This was a basal cell carcinoma, and you can see the result. This is what we did, pulled in from here. This was the defect created. I don't have the intra-op pictures, and this was the result. This is another one where we did Tenzel's. You can see there was a medial lesion, and you could pull in quite sufficiently. This was almost after 3 to 4 months, so the scars have faded of the Tenzel's thing. This is how you got the result. Then a free tarsal graft can be harvested from the ipsilateral or lateral. If you remember in the beginning, we talked about looking at the other lid for this reason. So we take the free tarsal graft from the upper lid, because that has more simply because it has more tarsal plate, and we take it from the place where the height of the tarsal plate is the highest. And this is used to replace the posterior lamella. Tarsoconjunctiva actually is taken, so that you get a smooth surface. Of course, it has to be supported with a myocutaneous advancement flap. We said one free graft and one flap. So Hughes is one of the tarsoconjunctival flaps, which you again support with skin here. Here, when there is a defect, generally central defects give best results. A little off center is all right, but if they are too much to a side, Hughes may not really give such a good result. But I have tried it even in quite lateral or medial lesions. Here you take there is a full thickness defect of the lower lid. This is in the center. And you take the tarsoconjunctival flap from the upper lid. It still derives, you just detach it 4 mm from the lid margin to maintain the contour of the lid. You don't go up to the lid margin, leave 4 mm here, and you pull it down and anchor it to this defect, the inner lamella of this defect. And for the outer lamella, you drag in skin either from the cheek or anywhere. You can also put a free graft, because this is a flap. So this is a Hughes second stage picture I have, where this was a Hughes done from the upper lid, and you can see we have released it, and this is the end result. Mustard we rarely use, especially for very big tumors medially. If we draw in skin from the cheek, this gentleman with a huge basal cell, and this is good for very large defects. Single stage procedure. Otherwise, other option here would be again a Hughes with a lot of skin grafting. You could take a medial flap also to cover the skin area, but this was quite a huge tumor, and margin clearance when you want to give, you have to take away a big area, of course. Sometimes if the basal cell carcinoma is only in the anterior lamella, you can get away with the anterior lamellar resection and a free graft. So upper lid reconstruction again is the same principles. I'll just show you examples. So this child had a trauma here. Here, see what happens if you don't square the defect, or you don't extend the full length of the tarsal plate, is you get a notching like this. You have seen in that picture before, which I have repeated here. So you have to extend the tarsal defect up to the entire width of the height of the tarsal plate. Then these are cases of colobomas where there are defects of different types. There are a little bit of tarsal plate is there, different extent of the defect, and you can sometimes manage with in this age of children. We do not really prefer Hughes, or we do not prefer Cutler beard or other procedures, because amblyopia is very, very possible to happen, and we like to Okay. Often we find that the defect is not as large as it's seen in the pictures. When you bring the two edges together with two-edged forceps, it is quite a small defect and you can get away with a canthotomy, cantholysis alone. These are the two results we did. Then tensile flap in the upper lid. We said it has to be oriented below. The lesion was in the upper lid. I'll not waste time here. Sliding tarsoconjunctival flap. Here you can take the entire lid and slide it. You can and slide it. Look at the defect here. You see we have slid it here. For the upper lid, this is the way the tensils is going. I'm not sure if you're able to see that scar, and it's coming quite up to this much of the lid, only about medial 1/3 was there. We managed to get quite a good flap and quite a good upper lid. Of course, there was a little bit of anatomical disfigurement. I would say no lashes in the lateral half, lateral 1/3 or even lateral 2/5 of the upper lid, but it was passable. Then you have the local myocutaneous flap. We already talked about the posterior lamellar graft, which we do. We can take it. This is a picture where we are doing a upper lid. There was a huge meibomian gland carcinoma, and we took that away. We put a tarsoconjunctival graft on the area left, and we put a free skin graft. Cutler beard is a bridge flap. Often in the exam, people are, because some of these procedures are named and commonly used by surgeons for their procedures, so they're named after them. So Cutler beard is a bridge flap. It is a full thickness flap, myocutaneous flap, only muscle and skin. It does not account for the tarsoconjunctiva, and you have to supplement it with tarsoconjunctiva if you want to have entire thickness of the lid formed. So it is used for large defects of the upper lid. Central defects work well with this. Again, if they're off center, they don't work so well. It is opposite of Hughes in the sense it's upper lid to lower lid. Also opposite in the sense this is only myocutaneous from the lower lid, because tarsal plate in the lower lid is very small and cannot really supplement this defect. So you can use a free tarsoconjunctival here and use this one free graft, and this you can slide. So depending on which lid, where is the lesion, we can modify. So these are few examples of the Cutler beard technique. Few examples of the Cutler beard technique where we had a lesion on the lid here. This is the stage 2 and this is the stage 3 where we have released. Another one where there was a melanoma on the inner side of the lid, and this was the after the surgery, and this was on the table after we removed it. Then pedicle flaps from lower lid are another option for children where they have trauma of the lids, and where you cannot close the eye. And if the trauma is sometimes central, or if the trauma is, you don't want to do Cutler beard, you cannot put a free graft for this defect, you can pull in some of the lower lid for the upper lid or vice versa. These again will be staged procedures, because you have to attach this to the canthus. I'm sorry, I did not put pictures, but I've done 3 cases like this. They require sometimes multiple stages, because in children there is a lot of contractility and the skin and everything contracts a lot. There is a notching at this place where you join the lower lid part to this, and this also doesn't stay so angled in the first sitting, sometimes 2 or 3 sittings, but this is also a good option where you don't want to close the eye totally. Then lateral canthal reconstructions, as we said, are very important. This lady had a total, because you need, that's a fulcrum on which the lid acts, opens and closes and forms the creases, and very necessary not just for cosmesis but for spreading of the tear film. Functionality always first, cosmesis always second, last but not the least. Medial canthal reconstructions are very important. Here you have to definitely put, these are a few examples where surgery, where repair was done outside by non-oculoplastic surgeons. Sometimes in emergencies, and if the patient comes from the periphery, not near the city, they are just have to tackle it because there's a lot of bleeding. And we can go back and redo it. In some of these cases, we have even tried to put a mini Monoca stent. We could find the cut end also even after 1 month, and it did give good results. That's another presentation. This is a small video. Do I have time to play this, or do I continue? Do I omit this?
Ma'am, we are already running out of
Okay.
time. If you
So
can
this is another class, so I'll just not go here. So in conclusion, you understand the eyelid anatomy thoroughly, basic techniques of repair, and definitely it is complex in situations, but if you're having a 3-dimensional vision, you can find out of clutter simplicity and harmony out of discord. And of course, opportunity always lies in difficulty. Thank you so much.
Thank you so much, ma'am. It was indeed a very much wonderful presentation. Even we as enjoyed a lot, and I think nothing to say. And I definitely am convinced that the PGs would have, taken notes from this wonderful presentation. Thank you so much. Thank you. And now I invite my friend Dr. Nupur Goyal from IKEA Noida, and she's a very famous YOSI member and executive as well. She will be talking about epiphora, differential diagnosis and investigations.
Yeah, thank you, Dr. Sumit, for the kind invite. And I hope my slides are visible and I'm well audible.
Yes, you are.
Yes. So at the outset, a huge thanks to the entire DOS team, Dr. Praful, Dr. Anu, for inviting me to this wonderful crash course. And I hope I am able to do justice to the topic that's been allotted to me, which is epiphora, very important topic at the postgraduate level and as a consultant level also. So just a quick diagram of the whole lacrimal apparatus. So you have the secretory path where the tears are produced by the lacrimal gland and the accessory lacrimal glands, and the excretory path, which is the lacrimal drainage system. So you need to differentiate between lacrimation and epiphora. So watering eye could be lacrimation or epiphora. Why do you need to differentiate? Because if you do not differentiate, you will end up with unnecessary investigations for the patients and unnecessary management for the patient. So lacrimation is watering that occurs secondary to excessive tear production in the presence of a normal excretory system, whereas epiphora is watering that occurs secondary to a normal excretory system in the presence of a normal tear secretion. So coming back, just going back to the diagram again, so epiphora is basically wherever there's an abnormality of the excretory system of the drainage of the tears. So, how does a normal tear flow? So the tear flows along the marginal strip, pooling into the lacus lacrimalis, as you see in diagram A. In diagram B, when you see as the eye blinks due to the contraction of the orbicularis oculi muscle, with each blink, it forces the tears are forced down the nasolacrimal duct from the lacrimal sac, and when the eyes open, the canaliculus and the sac expand, creating a negative pressure, which causes the tears to flow into the canaliculus and into the sac. So this is again a quick diagram. So the lacrimal apparatus comprises of the main lacrimal gland and the accessory lacrimal glands, which is the secretory part and which we are not concerned with today, and the lacrimal passage, which includes the puncta, canaliculi, lacrimal sac, the nasolacrimal duct, which opens into the inferior meatus of the nose. And this lacrimal drainage passage is the one that we are concerned with today with the epiphora. So coming to the evaluation of epiphora. So once again, epiphora implies overflowing of tears due to impairment of lacrimal drainage. The causes can be anatomical, which can be complete or partial, obstruction anywhere along the lacrimal drainage system, or it could be functional, which is a lacrimal pump failure due to anatomical deformity, either due to the laxity of the lids or the orbicularis weakness, wherein the tears are unable to get excreted into the lacrimal drainage system. So coming to the punctal causes, it could be a congenital agenesis or imperforate punctum. Acquired causes could be any occlusion, infection, radiation, any systemic causes causing punctal stenosis like pemphigoid, Stevens-Johnson syndrome, any burns, any tumors, or malposition of the punctum, which could be a medial displacement or a medial ectropion. Coming to canalicular causes, it could be a congenital absence or fistula of the canaliculus, or acquired it could be an intrinsic cause or an extrinsic cause. The intrinsic could be canaliculitis, trauma, post-radiation trauma, or any post-radiation tumors. Extrinsic could be compression by the adjacent tumors. Coming to the lacrimal sac abnormality, that could be a sac inflammation, a perilacrimal fibrosis, dacryolyth, any sac tumor, adnexal tumors pressing on the lacrimal sac or the drainage pathway. And the nasolacrimal duct obstruction, which could be congenital nasolacrimal duct obstruction, or a delayed opening of the Hasner's valve, craniofacial anomalies, or the agenesis of the nasolacrimal duct. The acquired cause could be primary or secondary to any tumor or trauma, or any nasal conditions like severely deviated nasal septum, which causes the blockade of the nasolacrimal duct. So coming to the clinical evaluation of a patient with epiphora. So first you need to start with a good history, a careful history, external examinations, slit lamp biomicroscopy, syringing and probing, and the imaging. So coming to history, so one must inquire about whether the epiphora is constant or intermittent, if there are any periods of remission versus no remission, it's unilateral or bilateral, if there's any associated subjective ocular discomfort, any history of allergies, use of topical medications, because some medications are known to cause punctal stenosis, any history of probing during childhood, which could, lead to that probably you might be dealing with a case of congenital nasolacrimal duct obstruction, any prior ocular surface infections, prior sinus disease or surgery, any midfacial trauma or nasal fracture, because these can be, secondary causes of the nasolacrimal duct obstruction, previous episodes of lacrimal sac inflammation, and whether the discharge or the epiphora is clear, or whether it's a mucoid discharge or it's a discharge of blood, because each of them could indicate to a specific etiology. If it's a bloody discharge, it could indicate that there's a dacryolith or probably a tumor which is into play. So then this is followed by a good slit lamp biomicroscopy examination. So go stepwise, check for any abnormalities of the eyelids, check for the position of the puncta, the size and the patency, any discharge, size of the caruncle, if there's any eyelid laxity, blinking mechanism, because this acts like a pumping mechanism for the drainage of the tears. Check for the marginal tear strip, tear film debris, and check out for any signs of ocular cicatricial pemphigoid. External examination. So again, look for the puncta and the eyelids. They should be examined using a slit lamp, as already mentioned. If there's any visible mucopollulant discharge, which could indicate a nasolacrimal duct obstruction, look out for any punctal stenosis. It may be asymptomatic, insufficiency of tear production or increased evaporation. Look out for any ectropion. Look out for any conjunctival chalasis, as it may cause a partial obstruction of the punctum by a fold of redundant conjunctiva. There might be an eyelash which may be lodged in the ampulla, which may be causing a temporary obstruction, and that may be leading to epiphora. A large caruncle may also displace the punctum away from the globe. So these are the certain examples, as mentioned: conjunctival chalasis, punctal obstruction by an eyelash in the ampulla, a large caruncle which displaces the punctum, or a pouting punctum which may be indicative of a canaliculitis. So lid laxity, the puncta may rarely override each other. A pouting punctum is typical of canaliculitis, and eyelid skin will often be moderately scaly and erythematous in chronic epiphora because of constant irritation and rubbing by the patient. Also, one must be aware of a condition called the Centurion syndrome, which is characterized by anterior malposition of the medial part of the lid with displacement of the puncta out of the lacus lacrimus due to a prominent nasal bridge. So this is again a functional cause of epiphora, and this is typically seen in males. So one must be aware of this condition also. So coming to the, also one must also focus on the nasal examination, note any anatomical abnormalities, hypertrophy, turbinase, nasal polyps, deviated septum, or any type of atrophic rhinitis. Now coming to the diagnostic tests. So these are the various diagnostic tests that one needs to, establish epiphora, the causes and further management. So a Roplast test, which is regurgitation of pressure on lacrimal sac, syringing or irrigation, followed by a diagnostic probing, a dacryocystography, dye disappearance test, Jones dye test, scintigraphy, CT or a MRI, and nasal endoscopy. So we'll just cover this one by one. So I would like to take some time to discuss about the syringing and the Roplast concept, because often this is something which looks very simple, but a lot of dilemmas are associated with it. So I'll cover the Roplast and syringing as 5 key points or simplies. So first coming to the anatomy. So one must always be aware of this lacrimal drainage system anatomy. So coming to Roplast concept, which is regurgitation of pressure over the lacrimal sac. So it's very important to know the exact position of the lacrimal sac. So here where is the lacrimal sac, which is situated in the lacrimal sac fossa. I'll go back again. So there's a fossa which is created between the anterior lacrimal crest, which is the medial wall of the orbit, and the roof of the orbit, which goes down posteriorly at the posterior lacrimal crest. And the fossa between the two is called the lacrimal sac fossa, and it is exactly where the lacrimal sac is situated. So why this is important? Because this is regurgitation on pressure over the lacrimal sac. So to be able to elicit a correct Roplast, you have to apply pressure on the sac directly. If you apply anywhere else, you will not be able to elicit a correct Roplast. So as you can see that you have to apply pressure directly over the lacrimal sac. So one key point is you can go along the floor of the orbit and then just go medially, and this is where your lacrimal sac is exactly. So quick video to demonstrate. As you can see, when you apply pressure, can you see a mucopurulent discharge which is coming? You apply pressure anywhere else, you will not get. Again, applying pressure on the lacrimal sac is where you're eliciting the Doppler correctly. So again, once you do a Doppler, you must be aware of the interpretation of the findings, what kind of fluid was regurgitating, if there was no regurgitation. So this is a quick table. In the interest of time, I'll skip this because we have other tests to cover as well. Coming to sac syringing, this is another very important test. So the one must be aware of the anatomy and the correct procedure to, it is a sort of an invasive test, but if it's done correctly, it gives you a lot of clue to the kind of obstruction that you're dealing with. So coming back to the anatomy, to do a correct lacrimal sac syringing, as we've seen that the punctum, there's an upper and the lower punctum, and the canalicular, there's an upper and the lower canaliculus, the horizontal and the vertical part of the canaliculus. So one must be aware that there's a vertical and the horizontal part, which then opens to the common canaliculus into the nasolacrimal sac, and then this opens via the nasolacrimal duct into the inferior meatus of the nose. So knowing that this vertical and the horizontal part is important, because this is how you should proceed with your syringing. You have to, whenever you're syringing, you must first go vertical. Then you must stretch the lid to make the vertical and the horizontal part align together, and then go horizontal. I'll give a quick demonstration of through a video. So this is how a sac syringing tray looks like. There's a punctum dilator with which you dilate the punctum. Then these are the lacrimal sac probes. Then you have I use a 1 cc syringe filled with distilled saline, distilled water, normal saline, and a cannula, a straight cannula or a bent cannula. Distilled water can be used. Alcohol swabs to clean it in between the procedure. So patient reclining position, you give a topical anesthetic drop. Then you fill the 1 cc syringe with your normal saline or distilled water. You explain the procedure to the patient. Remove any air bubbles. First, you dilate the punctum. You first go vertical, and then you give a little lateral traction. You go horizontal. So you go vertical with your cannula into the punctum. Then you give a little lateral traction. Then you go horizontal. And then once you get a stop, you adjust the hub of the needle, and then you inject the fluid, and you ask if the patient could feel any regurgitation in the fluid or the throat. Once again, so you dilate the punctum. You go first vertical. You give a little lateral traction so that the vertical and the horizontal part align, and then you stabilize the hub of your cannula, and then you inject the fluid. So it's very important that before you perform the procedure, you must explain to the patient what you're exactly doing, because the patient sometimes gets scared seeing the cannula. You tell them it's a blunt thing, it's not a needle, and you tell them that there's a small hole in your eyelid through which we'll be injecting a fluid. It's a clean fluid. If you feel it in the nose or the throat, not to get scared because they get a gag reflex, and to swallow it if they feel anything inside. So this is the thing. And again, yeah. And then you are sometimes the patients are unable to perceive. So you look for the deglutition movements. If you see that, you know that the fluid has come in the nose or the throat. So I'll just quickly skip and show that in one place where you could actually see the regurgitation of the fluid. So moving ahead. So again, sac syringing, just patent or not patent is not enough, because this just indicates there is some kind of blockade. But one also needs to know what level of blockade is there. So for this, we come to the concept of the soft stop versus hard stop. So when you put your cannula or the probe, if you're hitting the bone, if there's no blockade anywhere which is proximal to the canaliculus, you will hit the bone, and this is your hard stop. And if you get a soft stop, this is basically you're hitting the common canaliculus or any one of the canaliculus. This is a soft stop. So one must be aware of this concept. So and based on this, you can interpret. So a correct, good syringing documentation should have all of the following points: from which punctum have you done it, whether there was a hard stop or a soft stop, whether it was freely patent or there was any regurgitation. If there was regurgitation, what was the nature of the fluid, whether it was clear, mucoid, or blood tinged, and if there was a regurgitation from the same or the opposite punctum. Coming to the quick interpretation. So whenever you're doing a sac syringing, always have this diagram or draw this diagram whenever you're doing for easy interpretation. It's basically following the normal anatomy. So first, if you get a hard stop, then it could be either freely patent or it is not patent. If it is not patent and there's no regurgitation, then that means and then you check for Roplas. And if there's a regurgitation or fluid in the throat, that means you're dealing with an atonic sac. If there's a regurgitation, then you check whether it's regurgitation from the opposite punctum. That means you're dealing with an NLD block. If there's a regurgitation from the same punctum, that means there's an NLD block plus the opposite canalicular block. So coming to the soft stop, it can be the regurgitation from the opposite punctum. That means you're dealing with a common canalicular block. The nature of the fluid is clear if there's no associated canaliculitis. If there's regurgitation from the same punctum, that means you're dealing with the same canalicular block, and you need to repeat syringing from the opposite punctum. So again, the very important, why all this, the hard stop, soft stop, why do you need to know the level of the blockade? Because the source of the infection is the lacrimal sac. So anything which is proximal to the lacrimal sac is a condition where, probably patient does not have a risk of going into any infection, and you can safely proceed with any intraocular surgery. Anything which is distal to the sac is something which needs to be taken care of, because this is an infected fluid and this is a potential source of endophthalmitis. So quick, diagram, especially in cases where you're planning an intraocular surgery with respect to your syringing findings. So if the location of the block is in the lower or the upper canalicular block, can you proceed with the cataract surgery? Yes, if it is not associated with NLD block. So what will be the finding? The syringing will be freely patent through the opposite punctum. And no, if there's an associated NLD block. So when you do it to the opposite punctum, you'll get a hard stop with a clear mucoid or a fluid regurgitation. In case of common canalicular block, yes, you can proceed with the cataract surgery because your fluid is not reaching the lacrimal sac. So your sac fluid is not regurgitating. And definitely in case of nasolacrimal duct block, you cannot proceed with the intraocular surgery. So take home simply with respect to Roplas and sac syringing, the anatomy you should be well aware of. You should know how to check correct Roplas, sac syringing technique, hard stop versus soft stop, and source of infection is the sac. You should keep it in mind. So I hope with this that some dilemmas have been covered. Now coming to the other functional test for epiphora. So there is a dye disappearance test. This is especially important in case of children, wherein your Roplas is also negative and you are unable to do a sac syringing. So you instill a fluorescein dye 2% into the conjunctival fornices, and you check after 5 to 10 minutes. So if there's very little or no dye present normally, but if it is still persistent, that means there is inadequate lacrimal drainage. Coming to there is also grading for this dye test grading. So 0 is there's no fluorescein in the conjunctival sac. 1 is there's a thin fluorescein marginal tears drop which persists. 2 is more fluorescent persists somewhere between 1 and 3 grades. And 3 is wildly brightly fluorescent tear strip. So grade 0 and 1 are considered to be normal. So coming to the Jones dye testing, so this is more of I think a theoretical kind of thing. I do not routinely do it, but I'll be happy to know the comments from the panelists regarding that. So Jones one test or primary dye test is basically to differentiate a partial obstruction from the hypersecretion of tears. So you instill a fluorescein 2% drop into the conjunctiva, and after 5 minutes you take a cotton tip applicator and you insert it under the inferior turbinate. So if it is positive, there is a detection of the fluorescein from the nose, which means there's a patency of the system. Negative means the dye is not detected. It means there is either a partial or absolute obstruction or failure of the lacrimal pump. So as you can see, this is the Jones dye test. Positive when you see the fluorescein in the cotton tip applicator, and negative when there is no fluorescein in the cotton tip applicator. So Jones 2 test is the residual fluorescein is flushed from the conjunctival sac following a negative Jones 1 test. So if clear saline is placed in the inferior canaliculus using a syringe or cannula, and the irrigant is retrieved from the nasal cavity. So it is positive when the dye is recovered, the dye stained saline is recovered from the nose. That means there's a partial obstruction of the nasolacrimal duct, which you were able to overcome by injecting injecting it through the canaliculus. It is negative if there's recovery of still an unstained saline to the nose. That means either there was a total obstruction of the upper drainage system or defective lacrimal pump mechanism. So this is the Jones dye test. You irrigate some fluid. If you get it in the nose after Jones dye test, that means you are dealing with a partial obstruction. And negative is either you're dealing with a total obstruction of the upper punctum, or there's a lacrimal pump failure. So also one of the tests that can be done is a contrast, the cryocystography. So this involves injection of a radio-opaque contrast medium into the canaliculus, followed by the capture of magnified images. So the contrast which is used is 1 ml lipid, and it is injected through a catheter. Then multiple radiographs are taken. This is basically to confirm the precise site of lacrimal drainage obstruction and to guide surgery, and especially in diagnosis of diverticulum fistulae and filling defects in cases of a lacrimal sac. It should not be performed in case of acute infections. A normal cryocystogram is in the presence of epiphora suggests a failure of the lacrimal pump. So these are the images, wherein in the image A, you can see that there's a normal filling. In the image B, that you see on the right side of the sac, there is incomplete filling. So the other test which can be done in a case of epiphora is scintigraphy. This allows tear drainage to be assessed under physiological conditions and may be helpful to identify the location of a partial or functional block. So a technician 99 is delivered by a micropipette into the inferior conjunctival sac, and the trace is imaged using a gamma camera. So this is how the scintigraphy looks like. And as you can see that on the left side, there's a drainage in the nasolacrimal duct, if you can see this. So also one can, request for an imaging for a case of assessment of lacrimal obstruction. This is especially important in cases of trauma, to see if there's any bony chip which is blocking the nasolacrimal duct. In cases of infant with cystic mass at the medial canthus, amniocele versus meningeocele, any suspected malignancy. Also, a good test to have is in your armamentarium is a lacrimal endoscopy. So 1 millimeter rigid endoscope or fiber optic flexible endoscope is inserted through the puncta and canacle to inspect the lining of the mucosal lining of the lacrimal system and its contents, and one can investigate a DCR fistula using this. So these were all the in short, just covering the whole the causes, the clinical evaluation and the investigations for epiphora, and certain acknowledgements to Dr. Jyoti, Dr. Ransi, Dr. Uma, Dr. Arpita, and especially Dr. Kanchan, who have helped me put up this entire presentation. And so I hope that with this, I was able to sort of simplify, the complex evaluation and investigation of epiphora. Thank you so much.
Thank you, Dr. Nupur. Certainly, you have made that simple for us and very comprehensive, very, very comprehensive. And now there's slight change. Dr. Modini, ma'am, are you ready with the next presentation?
Yeah, I'm ready.
So ma'am will be talking about evisceration clinical pulse. Over to you, ma'am.
Yeah, so Dr. Nupur, congrats on a beautiful presentation. It's such a important, crucial topic, quite often not clear to the residents. So you've done a very good job with all your things. And I love the little men you used on your slides. I love to use them too. Really liked your presentation. Well done.
Thank you, ma'am. Thank you. Thank you so much.
Sorry for changing the program, Dr. Praful and Dr. Sumit, but I have some official Zoom meeting at 8. It just come
No
up.
problem,
So
ma'am.
I'm going
Thank
to go
you.
ahead with. I've modified the topic slightly to destructive surgeries. 1 second, yeah. Destructive surgeries of the eye, because generally the PGs are confused between what is enucleation, eviscerations, especially the indications, because many books have given many different things. So basically the destructive procedures of the eye are evisceration, enucleation, exenteration. All of you are very familiar with that after black fungus and mucormycosis in the COVID era. And of course, cyclodestructive procedures of the eye, which are not strictly a destructive procedure, but they destroy one part of the eye. So just for completion's sake, they're here. So the evisceration is defined as removal.
Ma'am, can you share the slides or you'll?
I have shared, haven't I?
We are not able to see.
Oh, sorry. I thought I was sharing them, man. 1 second.
Ma'am, you are such a senior teacher. I mean, you don't need the slides to convey the message, but I found that
No.
we
We need
cannot
to
see
have
the slides.
slides
Yeah.
because it is important
Yes.
to do that.
Yes.
1 second. Oh, I'm not
You have
finding
to
my
share the
slide.
screen
1
and
second,
run
1
the
second.
next presentation.
Yeah. 1 second. What's happening is it's on my laptop desktop. So मुझे 1 second, huh? Yeah. So sorry. Okay. Can you see it now?
Not yet, ma'am.
Not yet.
All right. Is that clear now?
Yeah, we
Now
can
it
see,
has
ma'am.
started.
Again,
Yes.
please
I'll
change
do.
it
Yeah,
to
yeah.
the
I'm just
slideshow mode.
going there. I'm putting the slideshow.
Yeah,
Okay.
thank you.
So sorry. Let me go back. Okay. Destructive procedures, like I said, are evisceration, enucleation, exenteration, and cyclodestructive procedures of the eye. Evisceration is the procedure where I want the postgraduates to really know. This is the procedure where the internal eye contents are taken out, leaving the scleral shell behind. And the muscles which are attached to the scleral shell are also left behind because they're outside the scleral shell. Anything outside the sclera itself and anything outside the sclera we leave behind in evisceration. In enucleation, you remove the entire eyeball, you leave the muscles and the orbital contents behind. Depending on the condition for why you're removing it, various parts of the optic nerve may be taken, a long stump, short stump, sometimes a muscle. It depends on why you're doing the enucleation. Exenteration, however, is removal of all orbital contents. Again, this is variable. You may remove lids, you may spare the lids, you may go up to the total end of the this thing. There are again combinations depending on the indication for exenteration. Cyclodestructive, of course, for ciliary processes in a painful blind eye for which nothing much can be done. For refractory glaucoma to relieve the pain when the patient is not fit for any other destructive surgery to relieve the pain. One sec. Okay. So evisceration was first described by James Baer in 1817 after he encountered a case of expulsive hemorrhage where the nature eviscerated the eye. It was not actually him doing anything. Maybe it was a very tense globe and an entry was made very fast and there was a difference in the pressure. So there was a expulsive choroidal hemorrhage which separated the retina and everything came out of the eye. So that was after that he only the scleral shell was left behind, and they named that procedure or that what happened as evisceration, and it started to be used for therapeutic and also treatment purposes, where all intraocular contents are removed while preserving the remaining sclera, extraocular muscle attachments, and surrounding adnexa. Often, this is done. Evisceration is preferred when the patient wants to have a cosmetic rehabilitation, where he wants a socket with good volume on which a prosthesis can be placed, which gives a good appearance to the patient. It appears as if he has two eyes, and they do not face the psychological trauma of going out into the society with an empty socket and a sunken eye. So the indications are generally for evisceration are non-responsive endophthalmitis which does not respond to medical management, intravitreal injections, where there is no hope left that the vision can be revived or the eye can be retained in that way. Only then evisceration is taken. So endophthalmitis, sometimes panophthalmitis, where you do a slightly modified procedure called a frill evisceration. I will talk about that later, where there is very bad penetrating ocular trauma, where you find the eyeball has already been severed, broken into pieces, and you cannot find the intact shell at all. You need to do this where you cannot revive the eye, where the scleral shell is not sufficient to be able to do anything with it. You do a evisceration. A blind, painful eye, definitely, where you can give a cosmesis along with relief of pain and everything. And then expulsive choroidal hemorrhage, of course, there is not much left with you. It happens automatically. A bleeding anterior staphyloма again can be relieved by an evisceration, where you can again cosmetically you can correct the eye. The contraindications, these are very, very important, often asked to the postgraduates in the exam when especially you do your instrument viva, are intraocular malignancy, known or suspected. If you have not done a B scan and demonstrated and demonstrated the lack of a malignancy in the posterior chamber, please do not go for evisceration, whatever the history of a patient. You must have a B scan or or a CT scan evidence that the posterior chamber of the eye is not having an intraocular tumor. Tumors and evisceration, you are only spreading, making it an extraorbital extension, the intraorbital extension of the tumor, and making the patient face worse surgeries and a worse prognosis. So never ever go for a evisceration, plan for a evisceration, write on the case sheet that it requires a evisceration. If you suspect, you have to prove an intraocular malignancy. Nowadays, suspicion is just the start. You have to prove it by evidence like a B scan, which is a simple thing available at most places, or a CT MRI. In thysis bulba and microphthalmia, often enucleation, evisceration cannot alone give you a cosmetic appearance because the scleral shell is too small to hold an adequately sized implant. So then you can definitely go ahead with cannot do a evisceration, you do a enucleation and you place a dummy fat graft or an orbital implant to give a cosmetic outcome. Now, before you go, you have to do a careful preoperative evaluation to rule out intraocular malignancy. This cannot be stressed enough. It is very, very, very important. If there is no view, B scan or CT is to be done. If cannot be ruled out, if there is a doubt, even in the CT and B scan, there is something like a mass, maybe organized subretinal, this thing, whatever is there, foreign body, something. If you're not sure, please don't plan for evisceration. Go for a enucleation, put an orbital implant or a dummy fat graft. You must make sure which eye you're mentioning in the case sheet at every place, even in the operation theater when we do the surgery. We have a check like we first before I start the surgery or the surgeon starts the surgery, you have to ask the resident which eye is posted. The resident will tell you the eye. You ask the sister which eye have you draped. So the sister again looks at the case sheets and tells you, because it is an totally unpardonable crime if you take out one eye instead of the other or you eviscerate. Of course, it is not possible for the indications that you miss the eye, but sometimes in small retinoblastomas or something, they have done one eye for the other. If there are bilateral and the eye you want to preserve and the bad eye, it has happened. So make sure the correct laterality. You can do it under general anesthesia or you can do it in sedation with regional an retrobulbar block. So these are the equipment, the speculum, the scoop, which is very, very important. This is another type of scoop, which is not a scoop actually. It just passes between the uveal tissue and the scleral shell. The iris scissors, the knife handle, which is used to make the first entry into the anterior chamber, the strabismus hook sometimes to hold to retract it. And of course, the suture tying forceps. These are the sterilizing trays, which you don't need to know. So you inject subconjunctivally also. Now the principle of evisceration is if most of the eviscerations can be people with eviscerations can be rehabilitated with a cosmetic appearance later on. That requires placement of an adequate sized implant. Then later on, once all the socket heals, you put a prosthetic eye in the socket. You place a prosthetic eye to give the patient a good listing. For that, you need to preserve as much conjunctiva as you want, as much as you can, sorry, not what you want, as much as you can. So therefore you inject a local anesthetic into the subconjunctival plane to balloon the conjunctiva so that you can take a 360-degree peritomy right at the limbus. Then you make a full incision into the limbus with a knife, then take scissors and excise the cornea. All the intraocular contents, including the uveal tract, etc., should be the lens, everything should be taken out. And they are always sent for anything you take out. The principle is anything you take out from the body, send for histopathology. Never compromise on that. There may be a lot of surprises waiting for you. The remaining uveal tissue, which is especially where the veins exit and where the arteries enter, there is some uveal tissue there. And that theoretically can give rise to sympathetic ophthalmia. So you want to clean all the uveal tissue. A good way is to take a absolute alcohol swab and pass it round and remove all the uveal tissue from the scleral shell. After you're satisfied, you've obtained hemostasis, then you make relaxing incisions because the scleral shell with only the cornea cut off is not sufficient for a proper sized implant to be placed inside. So you need to I have pictures of that. I will show you later. Then you evaluate the implant size. 20 mm is supposed to be the best, but sometimes you can get away with the 18 mm one, especially in younger individuals, women who don't have or people who don't have such a large eyeball. And you can supplement the cosmetic appearance with a thicker prosthetic eye. These are various materials with the implant is made, and it can be placed into the scleral shell. You don't need to wrap it in case of a evisceration. So this is the technique. You do a 4-petal technique, and this is where the implant, that is the PMMA implant. Various types, I'll come to that. This is after you have closed the tenon. So this is a small video showing you the 4-petal technique. You've raised the conjunctiva. Please tell me about the time, okay, Sumit, or please tell me the time, then I will talk or not talk about enucleation and exenteration.
Sure, ma'am.
Yeah. So you've removed the corneal button. Then this is the scoop which you pass in the clear plane between the sclera and the uveal tissue to make sure that you get the uveal tissue intact. Yes, that is the uveal tissue coming out intact. Even then, some part of it is left inside. There will be bleeding. You can see now the scleral shell. You have those alcohol soaked swabs which you're passing into the this thing. Clean it properly. If you're using a cautery, make sure the alcohol is out. Otherwise, it's dangerous, electric cautery. Then you have to make the petals, the 4-petal technique. Or you can make 2-petal technique also, where you're now placing the implant into the scleral shell. You're closing the sclera over it. And then you close the tenons and the conjunctiva. You can close them together or in 2 layers, depending on the friability of the tissue, because what is the primary condition for which you're doing evisceration decides the how the tissue is. I prefer Vicryl 60, but you can use other proline and other sutures also. You have to remove them only which are non-absorbable have to be removed. Many surgeons prefer catgut, but in my hands, Vicryl 60 works the best. So after this, these are the various types. You can use silicone spheres, PMMA spheres. There was a trend of using these porous hydroxyapatite, which were supposed to get biointegrated. Vessels do grow into them, and it is difficult to extrude these, but this somehow melted the sclera, which was anterior, and got exposed to the exterior and had to remove it, which was quite a task. This is the bio implant or the dermis fat graft, where you can reconstruct a socket where the eyeball has been removed. So these are the various types of implants you have. You may be asked in the viva, how do you reconstruct or how do you supplement the volume of a socket where the structures have been removed. So the orbital implant, and this is a conformer, a shell, which is similar to the shape of a prosthetic eye. This is a prosthetic eye here, and this is placed in the socket till everything heals and edema subsides, when you can remove this and place the appropriate sized implant. So this is a patient with, there is a conformer here, and then this is how it looks. Prosthetic eyes often do not have complete movement. You can see in one gaze, the prosthetic eye doesn't move except in that gaze. And we did a study and found that depth of the fornices is quite important for the movement of the prosthetic eye. There were pegged implants at a time, but none of those worked. Now coming to the complications, hemorrhage, orbital edema after the surgery, even if you don't do proper hemostasis post-operatively, lot of swelling, edema, vomiting. There can be, if you miss in spite of all my warnings, you can spread a malignancy and make a horrible situation for the patient and yourself liable to legal action. Then, of course, extrusion of the implant, if you do not suture it properly, if you used a ill-sized implant, if your sclera is very friable, this is what happens. And then definitely, because the operative time is shorter, less complex, and muscles are attached to the scleral shell, the movements are better. To talk about panophthalmitis, you have to do a frill evisceration where you leave a bit of the sclera around it, because you do not want to keep the entire scleral shell, because that's almost molten or eaten away, and you do not want to spread the infection through the meninges. So do not go up to the optic nerve. Leave a rim of sclera around it and take out the rest of the sclera. Those sockets you need to again put the implants after the infection and the edema has healed. So disadvantages are risk of sympathetic. Make sure that you clear the uveal tissue properly. Again, the second risk I do not really consider a disadvantage, because I will not allow it to happen. Of course, you don't get much specimen for histopathology, but whatever you get is sufficient, because most of the pathologies are in the uveal tissue and the retina rather than the sclera. And of course, if there are suspected or there is severe phthisis, you cannot do this. Enucleation, on the other hand, is a procedure where you remove everything except the extraocular muscles. You can see whatever is in violet, purple, and the optic nerve differentially. Do you have time? Or I can stop?
The time is over. The 10
Then
minutes are
we'll
over,
stop,
but
because
I
my
mean, if you
topic was
can.
evisceration, and I'm ready to take any questions.
I believe, ma'am, there is no slot for the interactive session. I mean, it
No,
No,
is.
no, no,
that's
no.
all right.
Sumit,
That's all
Sumit,
right.
Yeah,
They
it
Sumit,
is
can
there.
type the
Sumit,
questions and I will
And
answer.
ma'am, maybe you
Sumit,
can carry forward with the enucleation as well. Yeah.
Sumit,
Oh,
we
are you
had
sure?
kept time 5 minutes after discussion. So
Okay.
ma'am can
Okay.
wind up in 5 minutes
Yeah, yeah.
in
Acha,
nucleation,
acha,
no?
okay, let me see.
Yeah.
Or else we have the endophthalmic socket lecture. There
Yeah, I think
we
that will
can
cover
cover
it.
the
Yeah, I
yes,
think
ma'am.
Sumit, it will be a repetition. That's better.
Sure,
So
ma'am.
I request permission, Dr. Praful and Dr.
No, no,
Sumit to
ma'am.
leave because I have to just get
We
some
can't give
data
you
together for
permission.
my
Yeah.
official Zoom meeting now.
Thank you so much, ma'am, for.
Not at all.
Thank you
My
so much,
pleasure,
ma'am.
Dr. Praful, to talk to all the PGs. I'm always
Thank
happy
you
to
so
do
much,
it.
ma'am.
Thank you, Sumit. Thank you,
Thank you.
Sonam.
Ma'am,
Thank you all. Swati, thank you,
ma'am.
everybody else here.
just to inform you, ma'am, we have 530 PGs live now.
Oh, I'm
Oh,
so happy
wow.
about that. I hope I have been able to add to their knowledge. And I'm
Yes, ma'am,
always ready for
definitely.
any personal questions also if they want to ask me. Thank you and bye bye, everyone. And very
Thank you,
good
Ma'am,
ma'am.
can
initiative,
I ask
Praful.
you
Bye
a
bye.
question?
Yeah,
Ma'am, ma'am, what kind of ball implants do you prefer? PMMA ones or the silicone ones?
PMMA.
Ma'am, why not the silicones ones?
No reason except the cost, actually, to be frank, because PMMA costs lesser.
Okay. And
Silicon
ma'am,
are
what
not so freely available and the cost is little more. And we don't need the compressibility of silicon anyway.
exactly, exactly. And
Mm.
ma'am, what would be your preferred approach if you see there is like 2 by 2 mm ball implant exposure, maybe like 1 week post evisceration?
2 by?
2 by 2, a very little ball
Into
implant
two
exposure is
millimeters.
2
Yeah.
by 2
I would
millimeters.
first try to see if any sutures have given way and if my sclera is adequate enough. I could go back and extend my flaps, even detach it from the optic nerve if it is not sufficiently detached, and try to pull the patient's sclera to cover it. If the defect is larger, of course, maybe I have tried a scleral shell. I mean, you just take a
Little
scleral
patch, yeah.
graft and put it there, but that doesn't really work. And if the sclera, the cause of it is a very friable sclera, a very bad eye, which is not having this thing, then definitely I would take out the scleral shell and go for a primary orbital implant with a PMMA, wrap PMMA implant or something. Would not try to meddle too much because then you damage the conjunctiva a lot if you go on doing these procedures again and again. And a very good conjunctival fornices and conjunctival line socket is important for the movement transmission to the implant. So I would not tamper much. I would not try again and again. Once, if it is possible, otherwise just take out the whole sclera.
Okay.
That's my personal preference in my hands.
Thank you so much.
Thank you so much, ma'am, for enlightening us with your clinical pulse and vast experience in plasty. Thank you so much for taking your time out, ma'am. Thank
Thank
you.
you. Bye bye. Thank you.
Yeah. Now it's my pleasure to invite my colleague in moderation, Dr. Swati, for she'll be talking about congenital nasolacrimal duct obstruction. Dr. Swati, over to you, and I request you to now carry it forward after your talk. I'll be there, but yeah. Thank you. Over to
So are
you.
you able to see thank you so much,
No,
Dr.
not
Sumit.
yet.
So are you
Not
able to
yet.
see the presentation?
Not yet. You have to share the screen.
Okay, just a minute. Yeah.
No, Dr. Swati, I think there is some lag in your
Is
video.
it
Now,
visible now?
yeah, yeah. There is a lag in your this thing.
Yeah, is it?
Yeah, because
Okay, I mean my
I,
audio and video.
audio and video, yes.
Okay, should I continue?
Yeah, you please
Okay.
continue. I mean,
So a very good evening. Yeah.
but we are not yet able to see the screen.
Okay, then you keep on telling me in between if there is much lag. Okay, so in interest of time, very good evening to everyone out there, to the postgraduate students as well as the faculty members. And I would like to give my warm regards. Am I audible?
Yes, you're audible. Yeah, and now we
Now
can
we
see
can
your
see your
slides.
screen.
Okay. And I would extend my warm regards to Dr. Anu and Dr. Prafulla for inviting me here. So I would be speaking on congenital nasal duct obstruction, a topic which is very close to my heart. So you're able to see the next slide?
Yes, please.
Okay. So I would be taking this topic in these contents. So to introduce, the congenital nasal duct obstruction is essentially the blockage of the lacrimal drainage system. And in children, the majority of these obstructions are congenital and is usually caused by the persistence of membrane at the distal valve of Hasner. So 5% of the infants have these symptoms of CNLDO, and 80% have unilateral manifestation. And around 95% of these children, the symptoms are noticeable as early as in first month of life, and spontaneously resolution is noted in as high as 96% of the children in first year of life. So there are certain risk factors for developing CNLDO, like genetic predisposition, prematurity, perinatal infections, exposure to radiations. There are certain co-associations with CNLDO. As high as 30% children with Downs do have coexisting CNLDO. Others include ectodermal dysplasia syndrome, cleft lip palate, and other craniofacial abnormalities. So, to manage CNLDO, one should have a knowledge about the anatomy of the NLD system, which is very clearly enlightened by Dr. Nupur. So, I won't be going much into the detail. Coming on to etiopathogenesis, the lacrimal drainage system begins to develop when the embryo is at fifth week, 7 millimeter stage, wherein the region between the lateral nasal process and the maxillary process has a groove, which is called the naso-optic fissure. So the thickening occurs at the base of this group, and a solid rod of cells separate to move deep to the surface. Now this solid rod of cells begin to canalize at 4 months of age, first at the region of lacrimal sac, and then lastly the nasolacrimal duct. So the membrane of the puncta is canalized by seventh month, and the last end of the nasolacrimal duct often has a persisting membrane even at birth. And this imperforate membrane or the valve of the Hasner is the most common cause for the neonatal epiphora. And it also explains why premature children have a higher chances of having CNLDO. Any abnormal embryogenesis during this period can also lead to other regions of the drainage apparatus anomalies also, like punctal atresia or an abscess canaliculi or a lacrimal fistula or a diverticula. Other causes of neonatal CNLDO can be divided into anatomical, nasal cyst, and nasal masses like choanal atresia, dermoid cyst, nasolacrimal cyst, glial heteropia, and all. So, how do these children present to us? They'll present with excessive tearing or mattering, with a mucopurulent discharge and crusting of lid margins, and the swelling of the lacrimal sac. So, to diagnose them, so the differential diagnosis essentially are: there can be punctal agenesis. One must rule out acquired nasolacrimal duct obstructions, which can occur following any trauma or conjunctivitis. Congenital glaucoma is an essential differential diagnosis to be ruled out in a watering eye in a baby. Foreign bodies, acute conjunctivitis, keratitis, all can present as a watery eye in infants. So, to diagnose, regurgitation on pressure over lacrimal sac area gives you a mucopurulent discharge and has been already told by Dr. Nupur Goyal as to how to elicit it beautifully. The fluorescein dye disappearance test is regarded as an optimal diagnostic modality, provided that when once you put the fluorescent dye, the baby should not touch the eye or rub the eye within 2 minutes for you to give an accurate idea of the FDT test. And it is reliable to diagnose such obstruction, exhibiting a sensitivity as high as 90% and a specificity of 100%. The other investigation modalities like DCG, CT scan, ultrasound are done in cases when you are clinically in doubt of this diagnosis or there is an associated craniofacial abnormality. If untreated, CNLDO might lead to a significant hyperopia, which has been reported in 8% of the kids, which can lead to significant amblyopia in 5% of the kids. Recurrent conjunctivitis, inflammations, eye infections, and orbital cellulitis can also happen. So we have to manage this CNLDO in a stepwise manner. So first, primary management would be a non-invasive management, which is via Krigler's massage and can be done up to 6 months of the age, followed by probing, followed by balloon dilation or intubation, and DCR reserved for the refractory cases. So let's go through these management protocols one by one. So the Krigler's massage or the sac massage is the hydrostatic massage wherein there is a stroke of moderate pressure applied over the lacrimal sac in the downward direction for 2 to 3 seconds, and it is repeated 6 times daily. The success has been reported to be as high as 96%, but this number falls below 50% if the kid is above 10 months of age. The antibacterial eye drops are reserved for cases of severe or persistent discharge. The hygiene of eyelashes and eyelids is also essential. So, Krigler's massage or sac massage is easy to perform. It does not require any medical equipment and can be performed by the parents or the caregivers at home. When this conservative management fails to resolve CNLDO, usually the probing is done. Probing is advocated to be delayed till the child reaches 12 months to allow additional time for spontaneous resolution. Before probing, topical nasal decongestant and nasal packing is done to reduce mucosal swelling and widen the cavity for the better access. So early probing before 6 months of the age can also be taken in a case of a mucocele, a lacrimal sac abscess, or a significant dacryocystocele, or a condition called as amniotocele. Now, what is amniotocele? It is distension in the lacrimal sac, wherein the amniotic fluid enters the sac and is retained by a non-patent NLD and trapped by the valve of Rosenmuller. So that is also treated by probing. And you can also take probing earlier than 12 months in case you see that the parents are doing conservative management properly, and but there is still persistent CNLDO or there are recurrent infections happening. You can take that before 12 months. So how do we do probing? So in this procedure, a probe 00, a Bowman's probe, a 00 or 01, which is 1.1 millimeter in diameter, is passed through upper puncti. The probe is advanced along the canaliculus while exerting gentle lateral traction on the lid. Then it reaches the nasal bone, and then it is rotated 90-degree and gently introduced into the nasolacrimal duct and advanced into the nose. So the soft stop, if you encounter a soft stop, that means that there is a resistance distal or common canaliculus, and a hard stop means that there is a lacrimal bone where you have to turn the probe to the 90-degree. So you can confirm the duct patency in several ways. Just a minute. Okay. So the distal end of the probe in the nose can be palpated with another probe, achieving metal-on-metal contact. The small bolus of saline can be irrigated through the duct, and if the child is awake, you can see the swallowing lip reflex being elicited. And if the child is anesthetized, you can do the suction of the saline. The end of the probe can be directly visualized via the nasal endoscope, and the studies of primary probing have found it to be as successful as around 90%. But this success decreases with increase of age. In complex obstructions in the proximal part of the duct, they have a poor success following probing. NLD insertion. So it can be primary procedure or following failure of the simple probing, like in persistence of severe distal CNLDO, recurrent symptoms following initial probing, or a significant stenosis. It involves nasolacrimal duct probing followed by the passage of the nasolacrimal duct probe that has a stent switched to one end. And there is no difference between the stent insertion between monocanalicular or bicanalicular stent. But the NLD insertion following a failed probing has been reported to give a success rate of 66 to 100%. So when we are talking about CNLDO, we cannot forget about PEDIC study, which was an observational study and has shown a success rate of 78% in a simple probing till 36 months of age, and 88 eyes of failed probing undergoing NLD insertion to have a success rate of 84%. Now coming on to the balloon catheterization. So it is done as a primary procedure or can be done after the failure of the simple probing. And this is a YouTube video I've taken. The standard nasolacrimal duct probing is followed by the introduction of this balloon catheter, and it is inflated. And the success of the dilatation as a primary has been estimated as 53 or 95%. So you can see this is the dilatation of the balloon. So in the children who have failed primary probing and in children more than 18 months of the age as first treatment, the intranasal abnormalities were identified most commonly as nasolacrimal duct cyst, redundant duct mucosa, and distal membranes. So nowadays, the routine use of nasal endoscopy is advocated for nasolacrimal duct probing also as a primary procedure, because occasionally there may be membranous tissue flaps that can be removed while you are doing the nasal endoscopy, and you can also infracture the inferior turbinate while doing probing, and it will avoid failure of the primary probing procedure. So this is the table wherein this table postgraduates can make um, in their answer sheet, wherein the epiphora, if the age is less than 1 year, you can do the Krigler sac massage, and if the age is more than 1 year, you can go for a duct probing. If still the epiphora persists, you can repeat the probing once or twice, and if still the probing fails, you can either do a nasolacrimal duct intubation or a balloon decryoplasty, and if the child is more than 3 years, you can proceed with a DCR. So pediatric DCR is reserved for the children who have failed other procedures, or probably they have, like, a post-sacral bony atresia or complex obstructions, and it is not recommended before the age of 1 year. The external DCR has a reportedly excellent success rate in children, 96%, and the endoscopic approach is preferred by most pediatric ophthalmologists. Why? Because there is no external scar, you do not disrupt the medial canthus, and you preserve the normal lacrimal orbicularis anatomy. And the nasal endoscopy can also help in identifying intranasal abnormalities, as well as rectify the same at the time of the surgery. The use of adjunctive mitomycin C at the osteotomy site in endoscopic DCR has found to have increased successful outcomes. In cases of complete agenesis of the lacrimal duct, conjunctivorhinostomy with a permanent bypass tube may be indicated, but this surgery is generally postponed till the full facial growth has been largely complete by the age of, say, 10 to 12 years. So post-operatively, after probing, you can give antibiotic eye drops and nasal decongestant for 5 days, and can also ask the parents to continue the sac massage for a couple of weeks. And surgical follow-up after probing can be either an office visit or a phone contact, because the success rate of probing is quite high, and the parents are familiar with the signs and symptoms of unresolved obstruction. So office follow is usually left on an as when needed basis. So complications after surgical intervention can happen, like nasal bleeding, the duct can re-stenose, or there can be a creation of false passage of the duct on table. If you're doing a stenting, there can be an early loss of stent, or if you're doing a DCR, there can be early reclosure of the surgically created osteotomy. So talking about prognosis is generally quite good. The success rate of simple probing is excellent, and there is a higher chance post probing recurrence in patients who are more than 3 years of age. So to conclude, this congenital nasal duct obstruction is an anatomical anomaly of the tear duct drainage system, and most cases they resolve spontaneously within the first year of life. Diagnosis is essentially clinical, and the initial treatment is conservative observation, that is the Krigler sac massage. So these are my references, and hopefully I did justice to this topic.
Definitely, Dr. Swati, thank you so much for such a wonderful presentation. And I think without further delay, you can carry forward the session and invite the next speakers. Dr. Swati, can you hear me?
Yeah, now I can hear you.
Yeah.
I don't know whether you were able to hear me or not.
No. Thank you for such a wonderful presentation. It was very comprehensive and very well made. And now I request you to please kindly carry forward the session by inviting the next
Yeah, sure.
speakers. Yeah, thank you.
Sure. Thank you, Dr. Sumit, for your kind words. Now, I would be inviting Dr. Kirti Koka, who is one of the Dhurandhar oculoplastic surgeons at Shankar Netralaya, Chennai. And she would be speaking on proptosis, workup, and differential diagnosis. Over to you, Dr. Kirti.
Thank you so much, Swati. I think a little over thing of the other, but thank you. One second, I'm just sharing my slides. Are my slides visible?
Yeah, they are.
Yeah, okay, good. Okay, so my talk is going to be on proptosis management. How do you work up a case and the common DDs that you are going to be exposed to as a PG who's going to be going for the exams. So first and foremost, when you go for anything, you need to know what is the definition of proptosis, exophthalmos, dystopia, and pseudoproptosis. Okay, so what is proptosis first? So proptosis is basically the forward protrusion of the eye.
Your slides are not moving forward.
Just a second, it's moving for me. Just a second, I'll stop share and restart it again.
Dr. Kirti, I mean, they are not on the slideshow mode. Just make it a slideshow mode, and then they will move.
Yeah, I
You don't
have put
need
it
to
on
restart.
slideshow. Just a second. Mm, Is it moving now?
Yes.
Yes, they
Yeah.
are.
Okay. So, proptosis basically is a forward protrusion of the eyeball, whereas exophthalmos also technically means forward protrusion, but it means there's some active inflammation usually associated with thyroid eye disease. Dystopia is a non-axial proptosis. So, when you have proptosis, which is either going in a not forward, but either inferiorly or laterally, then it's going to be called dystopia. Whereas pseudoproptosis is not a true proptosis. Like here, you have this child with a shallow orbit where it appears proptose because the orbit as such is very shallow. Okay. The other cases of pseudoproptosis are eye appears proptosis because it can be myopia. There's a lid retraction which gives the appearance of a proptosis, but it's not a true proptosis. So you need to differentiate all this before you come to a conclusion of proptosis. Now, how do you classify a case of proptosis? Now, there are various ways to classify proptosis, and like all of you know, in anything you start with displacement. You can have it axial or eccentric. Laterality, whether it's just one eye, both eyes, based on etiology, you can classify them based on the onset into acute to subacute and chronic. Based on the age, you can divide it, and based on whether the proptosis is pulsatile or non-pulsatile. So these are various ways by how you can classify it based on the displacement. So sometimes examiner can ask you what are the DDs. Once you say that it is an axial proptosis, they will ask you for what are the DDs. So axial is just coming out forward straight. So it has to be things like thyroid, anything which involves the optic nerve. So it can be a glioma or it can be a meningioma, a CCF or AV malformation. Whereas eccentric involves any other kind of tumor lying in any of the quadrants, say the supromedial, supratemporal. So if it involves the frontal sinus, it could be a mucosal, lacrimal gland tumors. Okay, where sometimes from the maxillary sinus coming upward is a carcinoma of the maxillary sinus, or anywhere in the orbit you can have schwannomas and lymphomas. So these are examples. Look at this child. He's got a lesion here sitting in the supromedial, which is causing an infralateral proptosis. And this is the person having a tumor involving the superior as well as the lateral orbit. So you can see that the eye is moving down and inward. Okay. Whereas here you have a person whose eye is moving upward. This is a maxillary sinus. You can see there's a fullness over the cheek. There's a maxillary sinus tumor which is pushing the eye upward. Okay. So that's how you define for based on which direction the eye moves. Now, bilateral proptosis, most of your tumors, everything are generally going to be unilateral. So, if a person comes to you with bilateral proptosis, it immediately narrows down your differentials. It can be thyroid eye disease or systemic conditions like sarcoid vaginas, which can involve both the sides. Tumors, generally lymphomas are unilateral but can be bilateral. Leukemias in children and metastasis can be bilateral. Structures like I showed you, the initial shallow orbit craniosynostosis is going to be bilateral, and things like CCF and cavernous sinus thrombosis are all going to be bilateral causes of proptosis. I mentioned that you can classify it based on the etiology. So, inflammatory, vascular, cystic, benign, and malignant. You can classify it based on etiology into these. So, inflammatory, we know common ones are going to be your cellulitis. Then, other inflammatory things are going to be IUID and thyroid eye disease. Then, you can have even systemic granulomatosis with polyangiitis. Vascular causes, we dealt with CCF, I have already told you. Other causes like lymphangiomas or capillary hemangiomas can be the vascular. Cystic, dermoids and mucosals are the most common ones. Then you can classify into benign and malignant. Benign can be capillary hemangiomas, cavernous or lacrimal gland tumors, whereas malignant can be malignant tumors of the lacrimal gland, gliomas, meningiomas, rhabdomyosarcomas are all going to come under malignant tumors. Now, based on the onset, you can classify them into acute, subacute, chronic. When we say acute, it is something which is developing over 1 to 2 days, whereas subacute is something over a week, whereas chronic is something over 1 week to 2 weeks. Okay, so that's how it's going to go into chronic. So when it comes to acute, so something which is so acute and fast in onset has to either be a very malignant tumor, or it has to be something like an infection or an inflammation. Okay, whereas something over say 2 to 3 days to 7 days is something slowly happening. So those can be say vascular tumors into which a bleed is happening. Those can also be coming into subacute. But sometimes an acute bleed into a vascular tumor which is sudden onset can also, or a retrobulbar hemorrhage will also be acute. Okay, now subacute. Thyroid eye disease generally will be chronic, but sometimes they can present to you acutely. Okay, whereas other cases, like I said, a subacute can be like if there's a bleed into a lymphangioma, capillary hemangioma, some inflammation, or a dermoid which has ruptured, can all come under subacute to chronic category. Okay, now again, anything you classify based on age. So certain tumors are known to occur in children, like rhabdomyosarcoma will be then children, capillary hemangiomas will be in children. Whereas when you go to older age groups, the more common causes will be thyroid, lymphoproliferative, cavernous hemangioma. Okay. Similarly, if you look at glioma and optic nerve sheath meningioma, glioma is going to be seen in children, whereas optic nerve sheath meningioma will be more common in adults. So based on that, you should also be able to classify. Now, another thing is pulsations. Okay. Now, pulsations can be true pulsations, or they can be transmitted pulsations, or you can have tumors which are not pulsatile. So we all know thyroid is not a pulsating lesion, whereas pulsatile will be your CCF, meningoceles, encephaloceles, and all are going to pulsatile. So of this, if I like I said, you can have true pulsations and transmitted. A true pulsation is purely because of the arterial pulsation. So that is going to be a caverted cavernous fistula, whereas meningoceles and encephaloceles are going to be transmitted pulsations. Okay. So basically, when you approach a patient, you start always asking the history, because see, all these details will come to you in a history. One eye, both eyes, everything is going to come to you in a history. What is the mode of onset? Everything will come to you in the history. Only once you know the history, then go on to starting to examine the patient. Always examine the entire face, then go to the eye, then go to systemic examination. After that, you think of all the blood investigations and imaging which needs to be done. Okay, so you're going to ask about when the lesion first started, how did it progress, any vision loss with the lesion, double vision, aggravating relieving factors. Why aggravating? Suppose a person says it aggravates when I bend down, it is going to go in terms of a vascular malformation like a varix. Okay, now if a person gives you a history of diabetes in favor of cellulitis, thyroid eye disease, thyroid systemic thing, then it is more in favor of a thyroid eye disease. Okay, so all these are very important changes, things that you need to ask a person. Then you come to inspection. In inspection, you're going to see which eye, what is the type of proptosis. Then you check the palpable fissure height. If there's any scleral show, in patients with thyroid eye disease, they're going to have lid retraction. So you look for scleral shows. Then you look for any lag of ophthalmos. Then you always look for motility in all cases, any inflammation, and then go on to examining the mass. Okay. Before you go into that, you can do, before you start doing with the hurtles or going and touching the patient, you can look for whether there's proptosis. Suppose you don't have a hurtles, you want to see whether the person has a proptosis or in ophthalmos, you can do either the worm's hole view or the Navziger's view from behind the patient. You can measure proptosis with any of the instruments that you have. Most commonly we use the hurtles, but in case you don't have a hurtles, you can always do the two ruler method to determine the amount of proptosis. Palpation, examine the lesion, see what is the consistency, whether it is soft, it is cystic, or whether it is firm to hard. Okay, then check if there's any erythema on the skin, there's warmth. Then you look for whether the lesion is compressible into the orbit, whether pulsations are present, resistance to retroposition is called, we say that the RBR is raised. That means the tumor is behind the globe. Okay, and then you can also auscultate to see whether you have any bruise. In vascular lesions, you will feel bruise. So this is how you check for Valsalva. Okay, you have to ask the patient to completely bend forward with their hands loose and hold for 30 seconds, or you can ask them to close their mouth and blow again, close the nostrils and blow, which will show that if there's a vascular lesion, you will see that the amount of proptosis increases. Like here in this child, you can see that the eye has moved up, whereas in this person, you can see that the vascular lesion, the lid has actually become more prominent. Okay. So ocular, then after that only you move on to inside the eye. Why? Because certain lesions can affect the eye. Like in a person with cellulitis, their vision can come down. They can have disc edema, they can have RAPD. So it's all important to check for these patients. Thyroid eye disease patients can have corneal involvement. They can have raised intraocular pressures. Okay, they can have field defects because of compression of the nerve, and they can also have double vision because of movement restriction. So it's very important to document all these ocular examination findings. Then go on to regional and systemic examination. Okay, so I'm just going to run through a few important cases that can be asked for you all. So here we have a child who has a lesion involving the forehead and the eyelid. You can see that it's red, dilated vessels are seen on the surface. This is how the imaging looks. You can see an ill-defined lesion involving the orbit. You can see multiple flow voids inside this lesion. Okay, and this is a child after taking treatment with oral propranolol. So what is your treatment? What is the diagnosis here? It is going to be capillary hemangioma. Okay, so you need to know that capillary hemangioma is the most common benign tumor in children. Okay, it generally will start within 3 to 12 months and keep increasing in size, and they can spontaneously involute by 7 years of age. Okay, you generally don't treat them, but if they are going to obscure the visual axis, they're cosmetically not looking good, you can treat them. This is how they look on imaging: ill-defined lesions with characteristic flow voids that you will see inside the lesion. Okay, the treatment of choice these days is oral propranolol, whereas though there are various other treatment options, but most often most of these patients are treated with oral propranolol. Here is a child who was completely normal, but sudden onset. You can see this proptosis in this child after upper respiratory tract infection. And here you can see an ill-defined lesion which is having vascular spaces, which is seen in the intra and extracornal space. So what is this? It's a lymphangioma which worsens post a URI. So you need to know this is also a common benign lesion which is seen in children generally in the first decade of life and very characteristic on imaging. This can be kept as a spotter for you all. You can see this imaging here where you have there is hypo and there is hyper intensity lesions. This is called characteristic fluid levels because of layering of blood. That is very characteristic of lymphangioma. Treatment is generally you aspirate the lesion and you can give any kind of intralesional sclerotherapy. Bleomycin is most commonly used, where various other agents are also available which can be used as sclerosing agents. Here is a child who post trauma is coming to you with acute onset proptosis like this with vision drop. So what do you think of? Here you can see that there is a dirty appearance of all the preseptal and postseptal tissues. So this is a case of orbital cellulitis, and all you need to do is clinch the diagnosis and treat with IV antibiotics, and they respond very well. There's a patient who has a bad cough and cold, and then she develops an acute onset proptosis. With the lids are tense, you cannot even examine the globe. And this is what the imaging finding looks like. There's ill-defined inflammation involving the entire orbit. Again, a case of orbital cellulitis post sinusitis. Okay, so you need to know Chandler's classification. Sometimes examiners can ask you that. It goes from preseptal cellulitis to orbital cellulitis, subperiosteal abscess, and orbital abscess, and cavernous sinus thrombosis. Okay, it's very important to differentiate preseptal from an orbital cellulitis. Generally, in orbital cellulitis, pupils will start dilating. You'll have RAPD and you'll have decrease in vision. Okay, and there'll be increased proptosis. So you treat orbital cellulitis with IV antibiotics, whereas preseptal cellulitis you can treat with as an OPD basis with oral antibiotics. Here is a male patient who says he has this lesion in the upper lid since birth, which is slowly increasing in size. And that's how it looks on imaging, like a well-defined hypodense lesion with a hyper dense rim. Okay, and this is how it looks on table. So what are these? These are dermoids. And what are dermoids? They're chorostomas. They're generally located at the suture lines. Okay, there you have to do a CT scan to generally see if there's any bone involvement, and treatment is going to be complete surgical excision. Now, this is a child who's presenting to you with rapid onset proptosis. So, look at this child. Look at the amount of proptosis, and there's a huge mass lesion that you can see clinically. And look at the imaging. The eyeball is completely pushed to one side, and there's a huge lesion involving the entire medial orbit. So, what is this? It's a rhabdomyosarcoma. So, again, the question examiner will ask you the most common malignant tumor in children. That is going to be rhabdomyosarcoma. Again, there's a difference. Most common orbital tumor, rhabdomyosarcoma. Most common ocular malignant tumor will be retinoblastoma. Okay. So rhabdomyosarcos are common, and you should know the types. They are embryonal, alveolar, pleomorphic, botryoid. Earlier treatment was exenteration, but nowadays treatment is generally chemotherapy and radiation for these lesions. This is very common as a spotter. They will ask you what is the diagnosis. So you look at this: bilateral proptosis, upper lid, lower lid retracted, lateral flare. Okay, MRI showing enlargement of all the muscles. So this is thyroid eye disease. Okay, similarly, you have a patient with proptosis, localized inflammation. Okay, what is this? And here MRI showing enlargement of the lacrimal gland and inflammation of the lateral rectus muscle. This is IOID, idiopathic orbital inflammatory disease. So you need to differentiate both of these. So in idiopathic orbital, it will be sudden onset with pain proptosis, motility restriction, and generally IOID involves the lateral rectus muscle most commonly. Whereas in thyroid eye disease, it's an insidious onset, slow onset progressing proptosis. They will also have motility restriction, but look at the kind of muscle involvement. Here, the inferior rectus muscle is the first to be involved, followed by the medial, superior, lateral, and then the obliques. So, lateral is generally the last muscle to be involved. So, that's how you differentiate. Also, another important differentiating feature in thyroid eye disease, you'll have only the muscle belly involved, whereas in idiopathic orbital, you'll have both the muscle belly and the tendon involved on imaging. Okay. So like I said, IOID, you need to know the classification. Imaging findings, I just told you there'll be tendon involvement, and treatment is going to be steroids and immunosuppressants. Okay. Next, come to lymphoma. So lymphoma is the most common orbital tumor in adults. Okay. So adults, most common malignant tumors, lymphoma, most common benign tumor is going to be cavernous hemangioma. How do you find out? Most often they'll present you with proptosis, but many a time they will have this pinkish appearance lesion, which you'll see under the conjunctiva, that is going to be called the Salmon patch. Okay, and on imaging they will have lesions which will be molding around the globe like this. Okay, which is a very characteristic feature of lymphoma. How do you diagnose them? Histopathology will give you the diagnosis, and treatment, if it's going to be localized, is radiotherapy, and if it's systemic involvement, then it's going to be chemotherapy. So you need to get a PET scan done for these patients. So spoke about the most common malignant tumor in adults. Now this is the most common benign tumor in adults. So you have a female patient presenting to you with proptosis, and here imaging shows a well-defined intraconal lesion. Okay, and if you take out the lesion, this is how it appears, like a well-defined vascular mass. And on histopathology, you will see vascular spaces like this separated by fibrous septa. So what is this? It is a cavernous hemangioma. Okay, they're the most common benign tumors, generally occur in the middle age group. They're seen as well-defined lesions, and treatment is always complete surgical excision. Here, this again a spotter question. They'll show you this and ask you spot the diagnosis. So here, what do you see? You see an eye with dilated corkscrew vessels. And then if you look at the picture, patient has proptosis. Okay, so what is this? This is a carotid cavernous fistula. Such corkscrew vessels most often only seen in CCF. You need to know the Barrow's classification, A, B, C, D, where A is going to be a direct and B, C, D are indirect fistulas. Okay, so these patients will have a pulsatile kind of proptosis, and treatment generally is going to be, you have to do a DSA, MRI, and then it'll either be embolization for these patients, or you can even do what is called a carotid compression massage for the indirect type of CCF. On imaging, if you see, CCF patients will have a huge dilated superior ophthalmic vein. This is the superior ophthalmic vein that is dilated, and they will have enlarged extraocular muscles. So it's very important not to confuse on MRI enlarged extraocular muscles bilaterally and take the diagnosis as a thyroid eye disease. It's very important to look for these small features. Okay. Then coming to the lacrimal gland tumors, you have a patient who's presenting to you with proptosis, and you have some kind of fullness. Okay. So what is this? When you take an imaging, you're seeing a well-defined lesion like this in the region of the lacrimal gland, and you cannot see the lacrimal gland separately. So this is going to be a pleomorphic adenoma, which is the most common benign tumor of the lacrimal gland, and treatment is complete surgical excision. In contrast, this is an adenoid cystic carcinoma patient where you can see again a lesion in the region of the lacrimal gland, but it's rapid onset, and the eye, you can see there's a gross proptosis and dystopia. You can see the whole eyeball is displaced downwards. Okay, so this is generally an adenoid cystic carcinoma. Patients will complain of severe pain because of perineural spread of the tumor. Okay, and on CT scan, you can see calcifications also. So here again, the treatment is going to be complete surgical excision followed by radiotherapy and chemotherapy. So the take home message here is, in the orbit, though it's a very small limited space, you can have a wide variety of lesions. So this is a small mnemonic which will help you diagnose the condition. So based on the location, you can diagnose. So if it's going to be supratemporal, it has to be a lacrimal gland lesion. It can't be anything else. Okay. Based on the onset, you can subclassify. Clinical features are an important role. And most important, you need to have a knowledge about basic conditions which can occur to help clinch your diagnosis. Okay. Thank you.
Thank you, Dr. Kirti. That was as fantastic as always. Listening to you has always been an icing.
Thank you.
I am suddenly reminded of my fellowship days at SN.
Yes. Thanks a lot, Swati.
And now I invite Dr. Pratibha. She is also ex SN alumni, and she'll be speaking on thyroid eye disease. Over to you, ma'am.
Thank you, Dr. Swati. I'll be sharing my slides. Are my slides visible and am I audible?
Yes, ma'am, very much.
Okay. So, yeah, I'm Dr. Pratibha Nivian, and my topic today is thyroid eye disease. It's a very vast topic. It is very difficult to finish it in 10 minutes. As instructed, I would tell the salient points. So, thyroid eye disease is an autoimmune disorder which is characterized by inflammation and swelling of the orbital and periorbital tissues. It can cause simple symptoms like mild dry eye to severe sight-threatening complications like exposure keratopathy and compressive optic neuropathy. Coming to the epidemiology, this is the statistics from our own LV Prasad, the Indian study. The prevalence is it's an uncommon condition, but it's not a rare disease. It's like 100 to 300 per a lakh population, and the incidence is 16 per a lakh in females and 2.9 in males. We should understand that the incidence of thyroid eye disease is very common in females, but we should also know that if a male develops thyroid eye disease, the severity is more. And this is again from an Indian study. Patients with thyroid eye disease mostly are hyperthyroid. 50% are hyperthyroid, 25% are hypothyroid, and 20% are euthyroid. So this is a very important slide because we should understand that not all patients who have a thyroid status, it doesn't mean that patient cannot have a thyroid eye disease. And this slide shows that even TED patients can develop moderate to severe eye disease. So we have to follow up that thyroid eye disease patients with antibody titers to see whether they develop systemic thyroid levels in future. Thyroid eye disease can affect the quality of life, and it has been proven in literature. Coming to the pathogenesis, which is very important, and it has been extensively studied with a lot of research in this particular aspect. So basically, thyroid is an autoimmune disorder. So autoimmune means there is antibody production to self-antigens. So what they say is the CD34, the pluripotent cell, is the main culprit. There is some abnormality in that, and that causes antibody production to self-antigens. So antibodies are produced against TSH receptor, insulin growth factor receptors. These receptors are mainly present in the extraocular muscles, orbital fat, and lacrimal gland. That is the reason these three structures are commonly affected in thyroid eye disease. And there can be two types of disease. There can be a fatty disease or a fibrotic disease based on the pathogenesis. And this is again the cone theory, which has been recently explained with thyroid eye disease. So basically in thyroid, there can be a fatty disease or a fibrotic disease. So fatty disease, there can be a lot of proliferation of fat and hyaluronic acid deposition. This causes bulkiness of the muscles, and increase in fat also causes the globe to expand horizontally. So initially the globe expands horizontally, and then orbit cannot give way. So what happens? The fat tends to come and protrude in forward. There's an anterior posterior protrusion. That is why we see the fullness in the upper lid and the lower lid because of fatty proliferation. And then once that also cannot happen, then the compression happens. The nerves start getting compression. This is what is told in the cone theory. So we should understand the risk factors of thyroid eye disease. We know that not all patients with thyroid dysfunction develop an eye disease. So what are the risk factors? Smoking, uncontrolled TFT levels and receptor antibody titer levels, male sex, advanced age, and certain genetic typing are all said to be the significant risk factors. And one should understand smoking, thyroid function test, and antibody assay are the modifiable risk factors. The others cannot be modified. So we have to keep an eye on all these risk factors when we see a patient with thyroid eye disease. So how to diagnose thyroid eye disease? Way back in 1948, Gorman and Bartley had devised a criteria, and they say that lid retraction of and lateral flare are the more pathognomonic signs of thyroid eye disease. If they are present along with any of these findings like thyroid dysfunction or exophthalmos or optic neuropathy or extraocular muscle involvement, the patient is said to have eye disease. If the patient do not have an eyelid retraction or a lateral flare, then he should definitely have an abnormal thyroid dysfunction to say that the patient has a thyroid eye disease. So that there are various signs reported in literature. The very characteristic ones are the Dalrymple sign, that is the eyelid retraction in primary gaze, the eyelid lag in down gaze, the Von Graffies, bulbar congestion as in Goldseegers, Stellwax, Griffiths. There are so many signs. You can go back and read the literature, the very characteristic coaches that can be asked for the exams as a PG point of view. And this is again tachycardia along with goiter and thyroid eye disease is called as the Merzberger triad of Basedow. So what next? You diagnose that the patient has thyroid eye disease. So what should you do as a clinician? You should see for the activity and the severity. So way back when I did my PG, we were always doing VISA grading to detect the activity. So VISA stands for vision, inflammation, strabismus, and appearance. So this is a very detailed form which has the entire details about the thyroid, systemic thyroid parameters and also the inflammatory scoring. And when a patient has an inflammatory scoring of more than 4, the patient is said to have activity. And there is a follow-up form as well in VISA, which also gives us the prognosis whether the patient has worsened. But today, most of us have changed to the clinical activity scoring of Moritz because it is more simpler. It is very, it takes less time, and it is basically it is very simple, and it is very easy to understand. It basically takes into the consideration of the pain, the eyelid edema or the swelling, the conjunctival redness and chemosis, and scoring is being given for all these parameters. And if the scoring is more than 3 out of 7, then it says that the patient is active. And to follow up, to look for prognosis, there are 3 more parameters which has been assessed, and that says whether the patient has progressed from previous thing. And to assess the severity, European guidelines for Graves' orbitopathy, they have devised a guideline to say whether the disease is mild, moderate, or severe. To be more simpler, if it is said that the patient has a sight-threatening disease if the patient has a dysthyroid optic neuropathy or an exposure keratopathy. If the patient is said to have a moderate to severe disease if there is a lid retraction of more than 2 and an exophthalmos of more than 7. And the rest all patients are classified as mild. Many of our patients who come to the clinic have a very mild inactive thyroid eye disease like this. But why they have to be diagnosed early and have to be followed? Because very few subset of patients also develop a very severe sight-threatening and complex disease like that. So as ophthalmologists, as clinicians, we should regularly monitor them once in 3 months. We have to check the visual acuity, color vision, extraocular motility, intraocular pressure, which is very important. And the intraocular pressure is elevated in thyroid eye disease patients because of raised episcleral venous pressure and also the congestion of the vessels in the orbit. And pupillary exam has to be performed at every visit to see for any compressive optic neuropathy, and exophthalmometry has to be documented. Slit lamp fundus evaluation has to be done, and it is very important to document the visual field evaluation as a baseline, and it has to be repeated if needed. Then what are the investigations we have to do? As I already told, that the risk factors for progression is the modifiable risk factor is the thyroid level. So the free T3, T4, TSH has to be monitored at every level, at every visit. And these days, the laboratory have also been sophisticated with antibody titer evaluation. We can also make use of them because most of the time the thyroid function levels will be normal, but the antibody assay will be abnormal, and that is the reason for the patient to develop eye disease. So it's important to look in for thyroid stimulating immunoglobulins, antithyroid antibodies, and anti-thyroglobulin. And that is what I have told you about the euthyroid thyroid eye disease and the antibody titer importance. And yes, B-scan was an important diagnostic tool earlier, but because it is of low cost, it is easily available. It doesn't have ionizing radiation, but it is very difficult to do imaging, and the interpreter has to be skillful to detect the muscle and tell the size, and it might not be the same. It cannot be repeated every time. So B-scan is not the preferred choice of imaging, but the preferred choice of imaging is MRI. and MRI has to be done to look for activity of thyroid eye disease, and to look in for dysthyroid optic neuropathy. And in unilateral cases, for getting the diagnosis, we have to do an imaging. And before surgery, we do an imaging to see. But before surgery, CT is an ideal modality of choice, because we need to see the bony extent and the bony parameters and the amount of fat. If it is a fatty disease, our plan will be different. And to look for progression and follow up also, imaging is important. So what do we exactly see in imaging? So basically in thyroid, as we told, that there is a lot of collagen deposits, and there is edema of the muscles. So the muscles are hyper intense basically. So you can see the bulky muscle. The tendons are spared. And why the tendons are spared? Because the tendons have a lot of collagenous tissue. They do not have thyroid TSH receptors, but muscle belly has a lot of TSH receptor. Now coming back to the pathology, the TSH receptors, there is antibody for TSH receptors. So that is why the tendons are spared. And this is one of the very important sign which we have to see to differentiate it from the IOID. And MRI, so the muscles are hyper intense, and we can see the crowding of orbital apex. And there is something called as the orbital, the Barrett's index, which we look to detect the dysthyroid optic neuropathy. So so that is nothing but you add the muscle, superior rectus and inferior rectus, and and that should be more. If it is more than 60% of the total distance, then it means that there is signs of then there is chance of dysthyroid optic neuropathy. So as I told, CT is not the imaging of choice. MRI is the imaging of choice, but we do CT for diagnosing in unilateral cases when the patient cannot afford, just for the sake of diagnosis. And before any decompression, we can do a CT. And yes, the predictors of dysthyroid optic neuropathy are the Barrett's index, which I told you, and the apical crowding. So the differential diagnosis most of the differential diagnosis can be cleared from imaging. Orbital pseudotumor, the tendons will be involved. Yes, CCF, there will be a very prominent superior ophthalmic vein. Though thyroid eye disease might also have, CCF will have a very significant thing, along with other signs of CCF, the tortuous vessels and the tinnitus and other stuff. And orbital myositis will be very painful, and those clinical signs also will give us a clue. And orbital tumors will be very well delineated. The mass can be very easily picked out. Coming on to the management, so we saw we diagnosed thyroid eye disease. We detected the activity and severity. So one thing what you should understand is any mild inactive case should be only managed conservatively and should be followed up. Any active disease should be treated with steroids. If the patient has a moderate or severe disease, we can treat with steroids plus or minus immunomodulators, targeted therapy, whatever is available within our premises, and plus or minus orbital decompression. For dysthyroid optic neuropathy, intravenous methylprednisolone is mandatory, 3 doses, and then have to plan for an urgent decompression as early as possible. If there is a corneal damage, intravenous methylprednisolone with tasotherapy and an urgent decompression as early as possible. I'll be going in through the details. So the conservative management is same for all the cases. It is stabilization of thyroid, stopping of smoking, and conservative management of dry eye, and tablet selenium as supplementation, 100 microgram BD for 6 months. And coming on to any active case, I said we have to give steroids. Only for active case, we have to give steroids, not for inactive case. And coming on to whether it is oral steroid or IVMP, we should understand this table. So this is from proven literature. Oral steroids causes 30% remission. What is remission and relapse? Remission is the disease is coming down. Relapse is it is again coming back. So with oral steroids, 70% of the patients develop a relapse again. With intravenous methylprednisolone, the remission is 70% and relapse is 30%. But with immunomodulators, it is 80% of remission, and only the relapse happens only for 20%. And immunobiologicals, again, it is the same. So from this, what we understand is oral steroid, though it can reduce the symptoms, it can again relapse in a very severe or a vigorous way. So IVMP and immunomodulators are preferred modalities of treatment of thyroid eye disease. So I said IVMP is preferred, and this is the standard treatment regimen which has been given, the pulse IVMP. So weekly 500 milligram IV and followed by 250 milligram IV for the next 6 weeks. So this dosage will be slightly above to 4.5 grams of intravenous methylprednisolone, which people have reported side effects with such treatment. So people are, so now the guidelines is slightly revised. They say a low dose pulse IVMP, and they start with a 3-day 500 milligram IVMP, and then they give 500 milligram MP, 500 milligram MP weekly. And during the 4th week, they start immunomodulators. So what the researchers say is, when you bring down the when you are about to stop the steroids, you are starting the immunomodulators, and by the time when you stop the steroids, the immunomodulators will pick up its potency, and it will take care of the inflammation so that the patient's relapse is taken care of. This is the European guidelines, what I have talked. This is the guidelines which has been given by the UGOGO. So basically, mild thyroid eye disease, inactive, treat conservatively. For severe cases, treat with IVMP. Severe active cases, treat with IVMP plus or minus immunomodulators. The targeted therapy, teprotumab, this is very well talked about in the West. The TSH, it acts again, it is an insulin growth factor receptor antibody. It's given IV as IVMP along with steroids, and people have reported that there is a significant reduction in proptosis, but unfortunately those things are not available in India. But as postgraduates, you should be knowing about the targeted therapies as well. So basically, it's an inflammatory disease. Thyroid eye disease is an inflammatory disease. So there are a lot of inflammatory markers. So there are a lot of randomized controlled trials. There are a lot of targeted therapies against these inflammatory markers, and which researchers have also proved that these targeted therapies have reduced the proptosis and inflammation and have reduced the thyroid eye disease activity. The significant ones are for interleukin-6, that is the tocilizumab, TNF-alpha antibody, the etanercept and infliximab and adalimumab. And what is available in India is the CD20 antagonist, that is the rituximab, and teprotumumab is not available in India. It is very common. It is profusely being used in the West. So coming on to a little shorter thing about the surgical corrections. So surgical corrections can be done for moderate to severe disease once the disease activity has come down. So surgical corrections can be done for the proptosis, can be done for the lid retraction, can be done for the squint. As PGs, you should know the order of surgery should be this: the orbit, the lid, and the squint. Never go in the reverse order. The orbit, the proptosis has to be corrected with decompression. Lid can be corrected with a LPS recession or a graded blepharotomy, and then the squint can be corrected based on the squint what the patient has. There are future projections to detect biomarkers from tears, and then probably to see if that can give a clue about activity and severity very early, and so that we can treat them before they develop the active disease. These are few of our work on that. So the take-home message as PG should be: thyroid eye disease occurs in patients with thyroid. Systemic thyroid control is very much important, and the risk factors, the modifiable risk factors, have to be controlled. Not all patients with thyroid eye disease need steroid. You should treat patients with activity only with steroids, and you should also understand that intravenous steroids is better than oral steroids because the relapse is more common and more severe with oral steroids. And we should, as ophthalmologists, we should always follow up the patients of thyroid eye disease for compressive optic neuropathy, because that is very important because it can affect the vision. Thank you.
Thank you so much, Dr. Pratibha, for such a in-depth, crisp, and an absolute justification to such a difficult topic as of thyroid orbitopathy. So I guess there were so many learning and revising points as well for us faculty. So now, without further ado, I would like to invite Dr. Ashwati Neena. She'll be speaking on orbital inflammations, orbital cellulitis, and pseudotumor. Over to you.
Thank you. At the outset, I would like to thank Dr. Prafulla for this wonderful opportunity and Dr. Madhuvanti for considering me. Can I share my screen?
Yes, we can see that.
Yeah. The screen is visible now?
Yeah, it is now.
Yeah. So jumping right in, the topic allotted to me is orbital inflammation, specifically orbital cellulitis and idiopathic orbital inflammatory disease. So the first and the main line of defense lies the orbital septum, wherein anterior to it, any infection is called preseptal cellulitis, and posterior to it, all infections are called postseptal infection. So this septum is underdeveloped in children or in pediatric age group. That is why even a preseptal cellulitis is considered dangerous and are kept under regular follow-up. So the postseptal cellulitis was again classified further into 4 groups by Chandler way back in 1970. And it was classified as orbital cellulitis, subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis. It is important to note that it's not a true continuum and patients may skip stages. So if you see these 2 images, the first image shows a child with preseptal edema, but the globe as such looks normal. The vision, extraocular movement, pupils was normal and there was no proptosis. So that's a classical case of a preseptal cellulitis. While the second image shows a gross or baxial proptosis with congestion and chemosis. And if I were to say the pupil was showing RAPD and there was a defective vision, then definitely we are thinking postseptal cellulitis, most likely even a abscess because of the abaxial proptosis. But what about this case, wherein you have tense lid edema and you're not able to examine the eye? So therein, you cannot rule out an orbital cellulitis. That's when you start relying more on your imaging. So I'd like to leave you with this table differentiating preseptal and orbital cellulitis. The pathogens are more or less the same, but the inciting factors remain slightly different in that there are local factors like trivial trauma, hordeolum, which are common in your preseptal cellulitis, while in orbital, you can have more sources, which I'll come to in my next slide. Again, the main differentiating features lies in vision, extraocular movements, pupil, and proptosis. And orbit imaging is not considered mandatory for preseptal, but like exceptional cases like that are showed of the third case, we have to consider imaging even in preseptal. So there is defective vision in orbital cellulitis mainly because of 3 causes. Because of optic nerve compromise, either can be due to vascular compression or mechanical compression, or they can be optic nerve inflammation. So coming to the sources for orbital cellulitis, it can be from an adjacent paranasal sinus, which is the commonest, and that is also the ethmoid sinus that is involved, and dental infections. The eye itself, like endophthalmitis, dacryocystitis, can lead to orbital cellulitis. Then exogenous sources like a intraorbital foreign body or even an orbital ocular surgery like in a buccal surgery can also lead to orbital cellulitis. Then endogenous sources, of course. So why is it so important to know about orbital cellulitis? Because it's associated with dreaded complications like your cavernous sinus thrombosis, even orbital complications like abscess and orbital compartment syndrome, and then ocular complications like optic neuropathy, exposure keratopathy, and even arterial or venous occlusions. That is where your dilated fundus examination becomes important in a case of orbital cellulitis. So management, whenever asked, we always split it into investigations and treatment. So investigations, we have to do a baseline complete blood count and then blood cultures and culture of any nasal discharge that is available and imaging. So the imaging, what we prefer is a contrast enhanced CT of the orbit as well as the paranasal sinuses. And it's preferred in all cases, but then in a resource limited setting, we might have to become picky. So therein we have to examine all cases wherein we can't do a thorough examination, where we are suspecting an abscess like in an abaxial proptosis, when there's a defective vision, RAPD or disc edema, and definitely for planning your surgeries, and if there is an inadequate response within 48 hours. These warrant a emergent or urgent imaging. Now, I want to leave you with this flow chart. So here you can see in all cases of orbital cellulitis, suspected orbital cellulitis are admitted immediately and started on IV broad spectrum antibiotics like a 3rd generation cephalosporin. And a metronidazole can be added if you're suspecting an anaerobic organism. Simultaneously, we have to pull in ENT, physician or pediatrician, and baseline labs have to be sent. What has to be monitored is vision, color vision, pupils and extraocular movements every 6 hours minimum. And we need to mark the lid erythema and lid edema like this, or do a serial photography to mark the improvement or worsening. So once the imaging is done and we know there is an abscess, then definitely we go in for a surgical evacuation of the abscess if it's a subperiosteal or orbital abscess, like in this case, wherein the vision is also threatened, which is seen by the optic nerve posterior tenting of the globe or the guitar pick sign. Or if you have significant sinus disease, then endoscopic sinus surgery is indicated. And if the vision is threatened, then even an emergency canthotomy or cantholysis is required. Now, if the status is improving with IV antibiotics, then slowly we can switch to an oral antibiotic and even consider oral steroids if once we have ruled out the fungal infections after 24 to 48 hours of the antibiotic. So one of the dreaded complications is your cavernous sinus thrombosis. So therein you will have proptosis or the orbital inflammation becoming bilateral, and there will be total or partial ophthalmoplegia, facial anesthesia, Horner syndrome, and even altered mental status, fever, rigor, hypotension. So another main differential that examiners expect from you is how to differentiate between cavernous sinus syndrome, superior orbital fissure syndrome, and orbital apex syndrome. So everything that I just described in cavernous sinus syndrome can be seen in superior orbital fissure, except the V2 or the trigeminal maxillary branch of trigeminal nerve involvement and the Horner syndrome. Now, if you go for orbital apex, you will have all of that in superior orbital fissure added with the optic nerve dysfunction. This is important to know. Now, not just any infection can cause all these. You can have other differentials for acute orbit or hot orbit, that is your vascular lesions and neoplasias like rapidly progressive retinoblastoma, neuroblastoma, lymphoma, and metastasis in adults. And then you definitely have your specific orbital inflammations like sarcoidosis, Wegener's, or idiopathic orbital inflammatory disease, which I'm coming to next. So idiopathic orbital inflammatory disease, that is the preferred term now, or the other names are non-specific orbital inflammation. It was referred to as pseudotumor previously. Now it's considered a misnomer because there's not always a tumor present. So by definition, it's a non-infectious, non-neoplastic inflammatory condition affecting any or all of the orbital structures without identifiable systemic or local causes. And it is the third most common cause of orbital disease after thyroid and lymphoma. It's usually presenting as a unilateral disease, most commonly in adults and without any gender predilection. The exact pathophysiology remains unknown, but autoimmune dysregulation fits the bill mostly. So histopathologically, if you see in acute stages, it's a polymorphous without any specific cell. Polymorphous inflammatory cell infiltration can be seen. And in chronic stages, there's a lot of fibrosis seen. So clinical symptoms almost more or less resembles just like a hot orbit. The main characteristic clinical feature is that it is usually painful and it is usually more acute. So when you compare with the thyroid eye disease, it will have definitely a more of an acute or subacute presentation, while thyroid has a more chronic presentation. And pain will be much more significant than in your thyroid eye disease. Then if you see signs also, thyroid eye disease, lid retraction and lid lag on down gaze is a more prominent feature that will not be noticed in your IOID. And then laterality also, like I said, unilateral is much more common in IOID than bilaterality. And obviously your imaging will show tendon involving extraocular muscle enlargement in IOID, while it is a tendon sparing involvement in thyroid eye disease. So these are few of the points that can help you differentiate between thyroid and IOID. So coming to the subtypes, based on the subtypes, the symptoms can also differ. Symptoms and presentation can differ. So it's classified into diffuse and localized. Within localized, you have mainly dacryoadenitis and orbital myositis, which are the commonest ones. Then you have periscleritis, optic perineuritis, and the posterior or the apical version. So if you see dacryoadenitis, either of the lobes can get involved. If the palpebral lobes get involved, you have a S-shaped ptosis, or if the orbital lobe gets involved, you have a infromedial proptosis. There will be pain and tenderness and a palpable lacrimal gland with injection over the lacrimal gland. And if you have a bilateral disease, then your suspicion for specific inflammations like sarcoidosis or IgG4 goes up. And this is the easiest to biopsy among the lot. Now, if you come to orbital myositis, it's much more painful condition with pain being aggravated on extraocular movements, and there'll be congestion at the insertion of the muscles. And as we saw, the tendon will be involved in your inflammation. So the others include optic perineuritis, wherein the sheath is inflamed. There can be defective vision and pain with eye movement. And on imaging, you'll see a tram track appearance like how you will expect in a meningioma, but the margins will be much ill-defined in this, and they will show dramatic response to steroids. Sclera, tenons, and uvea can be inflamed this way. There can be a diffuse enlargement and brightening. So coming to the investigation, it is a diagnosis of exclusion. So our role is to investigate the patient. First, rule out infections, do CBC, MAN2, VDRL, then specific orbital inflammations like sarcoidosis by serum ACE, Wegener's by C-ANCA, IgG4 by serum IgG4, Sjogren's by anti-Rho and anti-La, and SLE by ANA and anti-dsDNA. Biopsy is considered if there is an approachable, distinct mass, and in cases where there is non-steroid responders and steroid dependency. And we always have to pull in our rheumatologist, pulmonologist, physician as and when required. So the treatment, mild disease, we treat with non-steroidal anti-inflammatory drugs. And moderate disease, we'll prefer a full dose of oral steroids. That's 1 mg per kg per day. We have to initiate and then taper the treatment only over 2 to 3 months. Sudden tapering or inadequate dose can also cause recurrent relapses. And in severe sight-threatening disease, we prefer a IV methylprednisolone. When patients are intolerant to steroids, we consider triamcinolone acetonide injections or even orbital radiotherapy. When there is steroid resistance or even dependence, we start immunosuppressants. Again, for all this, we need our rheumatologist's help. Now, this is a table which I have modified from this very article. So you can see first point in all orbital inflammations is to rule out the red flags. And if there are the red flags, then we definitely treat that as orbital cellulitis until proven otherwise. Then if there are no red flags, then orbital inflammation, one history which we have to rule out nowadays is this DIVA, which stands for drugs that can cause orbital inflammation, which include bisphosphonates and anti-cancer treatment drugs. And then inflammatory bowel disease again, which is coming up nowadays, and viral infections and autoimmune disorders. Then based on our imaging, based on the phenotype seen in the imaging, for each thing we can have separate investigations: myositis, dacryoadenitis, and diffuse. So all the investigations can be remembered as DROLA. So in that anti-dsDNA, IgG4, ANA, ACE, and ANCA, and anti-Rho and anti-La. So once we have sent off the investigations, we can definitely start a therapeutic steroid trial, provided all infections have been ruled out. And biopsy, like I said, can be considered when there is steroid non-response, steroid dependence, or atypical features, or the labs are suggestive of a specific orbital inflammation. So this is a table showing the specific orbital inflammations. You can go through this. Thank you.
Thank you, Dr. Ashwati Neena. Such an excellent presentation. Very nice. I mean, you're an excellent teacher. I believe the PGs would have taken a huge number of notes from your slides. Very nice presentation. And now I humbly request my colleague, Dr. Swati, my partners today in moderation, Dr. Swati, to please present her next talk.
Sumit, how many more we have left with?
Sir, only Dr. Swati and Dr. Manu Sen. That's it. Two.
Achha, so Swati is going to give that final touch. Huh?
Yep,
Welcome,
sir.
Swati.
Yeah, Dr. Swati will talk to us about blowout fractures.
For students, this is a very
Yeah.
important topic. You it is a long case.
Yes, sir.
It is given as a short note as well as in a long case. You can get that, or in a CT scan pic also. So can I start?
Yes, Dr. Swati.
Are my slides visible?
Yes.
Yeah. So I would be speaking on blowout fractures. I know it looks a little scary, but I hope to shed some dirt and give you a little clearer picture about what it is. So these are the contents on which I'll be speaking on. So, to introduce a blowout orbital fracture, basically it's a traumatic injury wherein the thin orbital bones, like floor and the medial wall, they break due to the blunt force, but they leave the outer rim intact. So, this is what is a blowout fracture with the rim intact. And in a blow-in fracture, what happens? The rim is fractured. Example: ZMC complex fractures. So the knowing or having the knowledge of anatomy is very, very important of the orbit. So what is orbit? It is actually a truncated pyramid wherein the base is facing in the front. So you can see I've deconstructed the pyramid schematically, and it is formed of the four walls: superior, inferior, medial, and lateral. Now between the superior and inferior lies the superior orbital fissure, which you can see here. And between the lateral and inferior wall is the inferior orbital fissure. So the key bones which are involved in the blowout fracture are the medial wall, the inferior wall, and the maxilla. So these bones are susceptible to fracture due to their thin nature. So understanding these bones is very important for your diagnosis, and the knowledge of orbital anatomy is also very essential so that you can see in the proper imaging and you can interpret imaging. So blowout fracture is essentially traumatic in nature. So as I was talking about the thin bone, if you see, this is the infraorbital foramen, wherein there is infraorbital neurovascular bundle. So just medial to it. So the floor, the inferior wall, just medial to the infraorbital foramen is the thinnest. And this is the bone which is generally fractured in the blowout fracture. And this is displaced down into the maxillary sinus. So once it goes down, the defect, the orbital contents herniate into the sinus, which can include fat, orbital contents, or even inferior rectus muscle. So that can cause double vision, diplopia, and entrapment of that may cause a severe oculocardiac reflex also. If the defect is large enough, there can also be a gross enophthalmos, and sometimes there can be more than 50% of the floor fracture is there. Even there are cases reported wherein the eye, the it is sunken into the maxillary sinus. I myself have seen that case in Shankar Netralaya. So, the mechanism for the blowout fracture have been described as buckling theory and the hydraulic theory. The hydraulic theory given by Pfeiffer is the most accepted one. So, let us understand what happens in hydraulic theory. So, one, the object is greater than the size of the globe, big enough not to perforate the globe but to give the direct blow to the orbit. That increases the intraorbital hydraulic pressure. Now this force is transferred to orbital soft tissues, which is the orbital wall and the soft tissues. So if it is a low force, it will only splay the inferior floor, but if it is a medium force, it will cause the fracture of the medial wall and the floor of the fracture, and will also cause soft tissue swelling as ecchymosis. Now coming on to trapdoor fractures, which are more common in children. Why? Because their bones are more pliable and more elastic in nature. So what happens when there is an inferior wall fracture in kids? The small hinged plate of the bone is displaced downward, the orbital soft tissues herniate in it, and then the plate hinges back upwards just like the trapdoor, and that entraps the orbital soft tissues. And suppose if the inferior rectus has also gone inside, it becomes entrapped. The kid will suffer from diplopia and severe oculocardiac reflex, which is an absolute emergency for the this floor fracture repair. Now, this trapdoor fracture is a little tricky because there is only a subtle defect on a CT scan, and it is seen as a teardrop sign. So, sagittal images or an altered orientation can give you a little hint of the inferior rectus ka altered orientation. So, coming on to the symptoms, the patients of fracture can present with blurred or double vision, the swelling under the eye, the swelling over the cheek area, the numbness over the cheek area, subconjunctival hemorrhage, or flattened cheek. They can present either with a proptosis or an enophthalmos, and also with a nosebleed. So white-eyed of fracture I've already discussed. So diplopia is referred to as a hallmark symptom of the blowout fracture, but that doesn't necessarily mean that it is due to muscle entrapment. It can also be due to the misalignment of the eye, or to the direct injury of the muscle, or due to muscle edema or hematoma. So CT scans are considered as gold standard for diagnosing blowout fractures, and thin cut axial CT scans of the orbit with coronal reconstruction should be advised. And in this CT scan, you can see that there is a large inferior wall fracture with the herniated orbital fat. Now, even if you see that the inferior rectus is herniated into the defect, that doesn't necessarily mean that it is entrapped. So entrapment is purely a clinical diagnosis and not a radiologic one. So early diagnosis is very crucial of blowout fractures to prevent long-term complications, and a structured approach to effectively manage blowout orbital fracture. So since they are traumatic in nature, so initially you have to stabilize the vitals of the patient and then establish whether the globe is intact and the intraocular contents are undamaged. Then do a proper ophthalmic examination, including vision, pupillary reaction, fundus evaluation. The extraocular motility limitation is there. If the patient is complaining of diplopia, do a diplopia charting. Inspect the periorbital area, look for ecchymosis, any deformity, any ophthalmos, asymmetry, or skin lacerations. Carefully palpate the orbit to look for any subcutaneous emphysema, wherein if the sinuses are breached, the air may have leaked out into the subcutaneous tissues, or any step of deformity that might be indicative of a rim fracture. There can be decreased sensations to V2, can be in ophthalmos. So once you have stabilized the patient, you can delay the orbital intervention. In case of any sight threatening complications, you have to address them first, like globe rupture, retinal detachment. Not all fracture cases require surgery. Many can be managed conservatively. So, advocate cold compresses for initial 48 hours, give antibiotics, analgesics. If you see that there is any bleeding, any laceration, give a proper tetanus prophylaxis. Patients with severe diplopia, you can benefit from a short course of steroid. Discourage nose blowing after for a month after injury. And diplopia should be evaluated again a week for improvement. And if there is an orbital fracture which is warranting a surgical intervention, it is usually delayed for up to 2 weeks for the edema and everything else to settle down. But immediate repair can be done in certain cases, as in there is a large fracture more than 50%, or there's a patient with a severe oculocardiac reflex with muscle entrapment, or there is a significant inophthalmos, or there is a progressive intraorbital hypothesia. Remember, the goal of the surgical intervention is to restore aesthetics and function. So, regarding the surgical approach, I'll be sharing a short video I saw in the YouTube. So, there are many approaches, but the most advocated one is the transconjunctival, wherein with a monopolar cautery just behind the tarsus, you give an incision and then you dissect between the orbicularis muscle and the orbital septum to reach the periosteum. Then you expose the fracture area. If there are any bony chips remaining there, you remove them. And then carefully, all the herniated orbital content, whether it is muscle, whether it is fat, you have to deposit it back into the orbit. And then place an implant large enough to cover a defect and ensure that the posterior part of the implant is onto the posterior ledge of the fracture defect so that it covers it completely. Now, implants can be either resorbable implants or titanium implants, alloplastic implants. So this is a customized lithographic fracture model. This also can be 3D printed. So you can get a 3D printed model of the based on the CT scan 3D reconstruction of your patient defect, and you can customize the implant according to the defect. And yeah, just yeah. So the implants can be autografts or alloplast. Titanium meshes are generally used for large orbital floor defects, whereas the resorbable implants are used for a smaller gaps and especially in the pediatric age groups. So these are the various kind of titanium implants. And once you put the titanium implant in the floor defect, you can anchor it with the screws, wherein once you use a resorbable, you can just put it on the defect, on the smaller defect, and allow the eye and the orbital contents to rest on it, and it will be in place. Or you can also use a cyanoacrylate glue to anchor it. So the post-operative care is very, very important. You have to 4 hourly monitor the pupil, the extraocular motility and the vision to look for any complications post-surgery. So lower lid retraction is one of the complications of the surgery, especially when you do a subciliary approach or you perform an excessive dissection. There can be postoperative enough and a persisting diplopia if you do not cover the posterior extent entirely with the implant, or if the implant migrates a little posteriorly, there will be still a residual increased orbital volume. And visual loss can happen, though it is very rare for you to directly injure the optic nerve, because the optic nerve is not near the defect, the fracture defect. But yes, if you do not secure the hemostasis properly, or you suture the septum very tightly, you should not suture the septum, that can lead to the compartment syndrome, and um, can lead to visual loss. So yes, monitoring the pupillary reaction is very, very important. So I hope that that much just is enough for the orbital blot fracture, and you will be able to write something if it comes in the exam. So these are my references. So to my take home message would be that yes, the initial management is very important, and you should know how clinically to identify, and also how to identify it on the CT scan image. And not all orbital fractures require surgical intervention. Thank you.
Thank you, Dr. Swati. It was indeed a mind-blowing presentation for orbital blowout fractures. So, with this, I think we came towards the end, and Dr. Manu is there. Dr. Manu Saini, last speaker of the session. Dr. Manu is here.
Is not joined.
Okay, Dr. Manu hasn't joined. So I think with that, we conclude the session. And Dr. Praful sir?
Dr. Praful sir has been constant with us throughout the oculoplasty session.
Yeah, despite his busy schedules. Sir, we have come to the end of the session, sir.
Thank you so much. Yesterday we went till 9:30, and thank you to all the students. And just to inform you, because for a moderator, for an organizer, it is important how much people are there till now.
Yes.
So we are still 394 students live. Thank you to all of you for having
Oh,
patiently
that's
sitting here.
really grateful.
And let me tell you another figure. We have 1698 registration for this course. Yesterday it was 1400 for cornea, but for plastic it's 1700. Great.
Nice.
Thank you all the students. And just there are few queries by student. I would like to sort it here. Everybody is asking if the videos will be available in YouTube. So immediately it won't be available because all the module, the video model size is going to be huge. So for to put that in YouTube, we need some subscription, some sponsorship, something like that. But rest assured, I'll ensure that you get all the recorded videos, but it may take some time. That is one. Second, request to all the speakers. We have promised them, or all the students, that we'll share them the PDF of the PPTs. So I request you all, please share the PDF of your PPTs. You can, if you are a little worried about the original pictures, you can exclude them. But at least the main content PDF you can share, so that the student can revise it, do a rapid revision in the end when they need during the time of exam. So these are the two clarification, students. And whichever link you are registering, just click that at 6 p.m. That link becomes active at 6 p.m. And thank you, Sumit, and thank you, Swati. The most important part for all these modules were moderator. So when I was discussing with Dr. Anu and Dr. Madhuvanti, we were like, कि कौन हमारा moderate 3 घंटा बैठने करेगा?
I
And
would say really hats off to Dr. Sumit, because मुझे तो end तक रहना ही था. My two presentations were there, but he was constantly throughout this. I guess at the end of this oculoplastic session, आप दोनों भी एक बहुत बढ़िया oculoplasty surgery कर सकते हैं.
Yeah,
yes.
thank you, Dr. Swati. I mean, you were a great partner. And thank you, Prafulla sir, for giving me the opportunity. And thank you for being there. Despite busy schedule, sir, at RP Center, we see you. And of course, during the election things.
Yes, please support me. Although
Sir,
this
all
is
the
not
best.
for
I
We are
request
election.
everyone to please support Praful sir, and all the best to you, sir. Yeah.
Thank you so much.
Yeah.
Good night, good night, good night,
Good
everyone.
night,
Thank you to all
everyone.
the speakers.
Thank you. Yeah.
Thank
Very
you.
excellent presentations.
Everybody's presentation was just crisp, short, and they covered all the important points which are asked in the viva or in the question papers. That was very nice.
Thank you, everyone. Thank you so much. Thank you, Dr.
Good
Swati.
night, good night.